Good morning, everyone. We're live.
And good morning, everyone. We have two meetings today. The first one will be the MOAT committee meeting, which I will chair, and then we will transition right after that into the Barbara Blakeney will chair the CDT committee meeting. So what I want to do at the start is we have two big topics today, but I want to ask David Seltz if he would introduce them and also particularly indicate things about to the public, how they can get access to the meetings and so on. So let me turn the proverbial microphone over to David Seltz, and it's good to see you this morning.
Good morning. Good morning, everyone. Colleen, can you hear me? Great. Well, welcome everyone to this meeting of the MOAT committee. As Professor Cutler mentioned, we have two meetings back to back. All of the materials will be posted on our website, and thank you for joining and viewing this through the YouTube channel. So we have two really packed agendas for these meetings. Today, we're going to start off with a research presentation on a legislatively mandated report on children with medical complexity. And after that, we're going to shift and do a deeper dive into some of the policy recommendations that were included in this year's cost trends report, which was the topic of conversation at our last board meeting. So what we'd like to do is really focus on recommendations number 1 and number 2 about strengthening accountability of our cost containment effort and addressing excessive pricing. So we're going to have some new data, some new research there as well to really go deeper on what those recommendations are going to be. And then in the second meeting, we're going to have a lot more topics there, which I'll introduce at the beginning of that meeting. So I think we're going to start off with the minutes, and Colleen, can you help us just walk through this?
Absolutely. I think we just need a motion.
Motion to approve.
And a second.
Let me make sure we can see everyone. Got it.
Got everyone.
So do we have a motion and a second? Second. And then I suppose the question is, does anyone have any amendments to the minutes at all? Okay, hearing none. Colleen, I believe we have to do this by roll call. Is that correct?
No, yeah, absolutely. We'll start with you, Professor.
Approved.
And Commissioner Haupt.
Approved.
Commissioner Mastrogiovanni.
Yes.
And Commissioner Roeder.
Approved.
And that's it for the votes today. Thank you so much.
And just so that we know, Tim Foley is abstaining from the voting because he was not at our last meeting. Is that correct?
That is correct. Yeah.
Okay, so we're not.
And he may join us a little later. He was tied up this morning.
So we're not purposely excluding him for any.
That's correct.
Any reason? Okay. So I think I will turn it back over. I think I now will turn it back over to David Seltz to introduce the first of our policy areas on children with medical complexity. David, is that right?
Absolutely, thank you. And I can turn it really right over to our lead researcher on this, Sasha Albert. So Sasha is going to walk through the background of this report, our findings, and really interested in your feedback, engagement, input, as this report is still a work in progress. We're really here today to present some preliminary findings. And so your comments will help us shape the final version of this report. So please, there's a lot here, but interrupt, ask questions. We really want this to be a back and forth discussion along the way. So with that, I'll turn it over to Sasha.
Thank you so much. Good morning, commissioners. I'm pleased to share preliminary findings from our report to the legislature this morning on children with medical complexities in the Commonwealth. Before I begin, I'd like to thank my colleagues on the research team, without whom this work would not have been possible, especially Justin Keel, Leiden Marcelat, and Laura Nasuti. Next slide, please. To better understand the landscape of children with medical complexities in Massachusetts, the legislature has charged the Health Policy Commission with estimating the number of children with medical complexities in the Commonwealth, their demographics, primary diagnoses, health coverage, access to and utilization of healthcare, associated costs, and recommendations for ongoing data collection and reporting. Next slide, please. Just for some brief background on children with medical complexities from the existing research. Children with medical complexities are a diverse and high-need population who are characterized by serious, chronic, and often multiple medical, mental, behavioral, or developmental health conditions, including functional limitations, high health service needs, and high utilization. They often require surgery or inpatient care and often rely on durable medical equipment and supplies, medical technology, or home health services. Next. A bit about our report. Children with medical complexities are a high-need population with significant use of health and social services, and our fragmented health system is not always set up to support them. So for this study, to understand children with medical complexities and their healthcare landscape in the Commonwealth, the Health Policy Commission investigated their demographics, health coverage, health service utilization, and spending. We also met with stakeholders to understand issues not measurable in our administrative data, such as access to care, care continuity, and social complexity for families. Next. We can keep moving. Many different health and social service systems are required to care for children with medical complexities. Fragmentation across these systems can be difficult for families to navigate, as parents must coordinate across systems not always designed to work together. Next slide. So this infographic gives a sense of what this can mean in Massachusetts in terms of the many and often overlapping health coverage and social service programs that support children with medical complexities. Here I'd like to point out the few pieces of text that are in color, that is commercial health insurance and Mass Health MCO, ACO, or managed care plans. These are the areas where the Health Policy Commission is able to provide insight. We call out Mass Health managed care plans specifically because those are the types of plans we've been able to include in our analysis. However, I do want to note that children with Mass Health Standard or with common health coverage generally are in managed care plans unless they have primary commercial insurance, which brings us to another important point, which is that our analysis of commercial spending currently does not capture any additional spending that a child may incur if they also have Mass Health as a secondary source of coverage. Mass Health secondary coverage for commercially insured children is used to cover out-of-pocket expenses, as well as additional services such as long-term services and supports. As a result, while the commercial spending we report here should be complete, the spending we're calculating provides an undercount of how much the Commonwealth spends on children with medical complexities and their families, because our preliminary findings do not yet capture secondary Mass Health spending for children with commercial insurance. Next slide. Better illustrate what navigating multiple health and social service programs can mean for families, we have an example of one family's care map. A care map is a family-created diagram that puts the family at the center, depicting the constellation of providers, services, and supports needed to care for children with medical complexities. So this image shows the many health services and social service programs needed to care for one child with complex medical needs. I'd like to note again that while children with medical complexities rely on a variety of social and school-based services in addition to healthcare, our quantitative analysis focuses only on their interaction with the health system. Next slide. So how many children do have complex medical needs? Research estimates that children with medical complexities represent 1 to 4% of children, which would translate to approximately 14 to 56,000 children in Massachusetts. Next slide. Next. So for this report, we use both of our main sources of administrative data, which include claims data and hospital discharges. We use each data source to answer different questions. Our claims data includes claims from the 5 commercial payers listed on the slide, as well as from Mass Health managed care plans. Claims include all types of care as listed across the top of the slide, but only for the individuals covered by those types of plans. By contrast, our hospital discharges include everyone with an inpatient or emergency department stay in Massachusetts across all types of health coverage, but only those services received inpatient or in the ED. Next slide. As children with medical complexities are a diverse population, we used an algorithm designed to identify medical complexity in pediatric patients to identify children with medical complexities in our data. This algorithm uses diagnosis information to sort individuals aged 21 and younger into 3 categories: non-chronic, non-complex chronic, and complex chronic. Non-chronic includes healthy individuals with no diagnoses or with diagnoses that resolve in less than a year, such as ear infections. Non-complex chronic includes individuals with chronic diagnoses lasting more than a year, such as ADHD or type 1 diabetes. Complex chronic includes individuals with multiple chronic diagnoses, for instance, ADHD and type 1 diabetes. It also includes progressive conditions such as cystic fibrosis, continuous dependence on technology, or malignancies such as leukemia or lymphoma. These distinctions are important because chronic conditions that are not complex on their own can become complex if an individual has more than one of them. Conversely, diagnosis alone does not inherently make an individual medically complex. Complexity also requires high service needs and functional limitations. For example, a largely asymptomatic individual with a cystic fibrosis diagnosis may not necessarily be medically complex. Next slide. This slide shows our use of the algorithm discussed on the previous slide to identify children with medical complexities in inpatient hospital stays. Our analysis includes individuals from age 1 to 21 in order to omit stays in the NICU. Overall, individuals aged 1 to 21 represent only about 4% of all inpatient stays in Massachusetts each year. That is to say, inpatient stays among children and young adults are rare events. For identifying children with medical complexities in 2018 inpatient stays, we use the complex chronic group as equivalent to children with medical complexities, representing about 8,000 individuals and nearly 13,000 inpatient stays. As pediatric inpatient utilization is fairly rare, children with medical complexities represented 32% of individuals and 41% of hospital stays among Massachusetts residents age 1 to 21. Next slide. The demographics of this group of children with medical complexities, that is, those who received inpatient care, indicate that children with medical complexities who received inpatient care in 2018 are more or less evenly spread across demographic groups. About half are male, about half are female, and we also see similar proportions of children with medical complexities and children without medical complexities by race and ethnicity. Half of children with medical complexities who had inpatient stays are ages 15 to 21, and 2/3 live in lower income zip codes. Next slide. On length of stay, children with medical complexities with inpatient hospital stays have nearly double the length of inpatient stay of children without medical complexities with inpatient hospital stays. Children with medical complexities were in the hospital for an average of 6.5 days, compared to 3.6 days for healthier children. Next slide. Most inpatient stays for children with medical complexities took place at only a few hospitals. This slide shows the top 15 hospitals for children with medical complexities inpatient stays in 2018, reflecting 85% of all of their inpatient stays that year. As shown on the slide, 36% of children with medical complexities inpatient stays were at Boston Children's Hospital. Next slide. We'll now turn to our other data source, which is medical claims. As claims include all types of healthcare utilization, we were able to be a bit more refined in our identification of children with medical complexities. For individuals with commercial and mass health MCO or ACO coverage, we refined those who were flagged as either complex chronic or non-complex chronic using the spending and utilization criteria listed on the slide in the lighter blue boxes towards the bottom. For an individual to be considered medically complex, they needed to have at least one of these spending or utilization factors. This resulted in about 9,000 commercially insured children with medical complexities and nearly 8,000 children with medical complexities with mass health MCO or ACO coverage. This represents 4.5% of the commercial population ages 1 to 21 and 6.4% of the mass health managed care population age 1 to 21. Next slide. Commercially insured children with medical complexities are more or less evenly spread across demographic groups. About half are male and about half are female. They make up 3.6% of each age group, though we do see slightly higher rates of children with medical complexities in older age groups, ages 15 and up. Half of commercially insured children with medical complexities live in higher income zip codes, which reflects the overall distribution of the commercially insured population. And we found that 1 in 5 children with medical complexities with commercial insurance have mood disorders, such as anxiety or depression. Next slide. Similarly, we see that children with medical complexities with mass health managed care coverage are spread more or less evenly across demographic groups, although we do see slightly higher rates of children with medical complexities with mass health MCO or ACO coverage overall as compared to children with medical complexities with commercial coverage. Again, about half are male and about half are female, and they make up about 6 to 11% of each age group, representing a higher proportion of individuals ages 19 to 21. Most children with medical complexities with Mass Health managed care coverage live in lower income zip codes, which again reflects the distribution of individuals with this type of coverage. Next slide, please. Now turning to spending. In all categories of spending, commercially insured children with medical complexities have significantly higher spending per member per year than children without medical complexities, with over $36,000 in spending per year compared to about $2,000 a year for healthier children. Separately, we measured spending on durable medical and equipment and supplies with slightly different methodology that identifies claims for DME in a way that's a little more relevant to this patient population. And we found over $2,000 in DME spending for commercially insured children with medical complexities, compared to about $250 for children without medical complexities. Next slide. Likewise, children with medical complexities with Mass Health MCO or ACO coverage have much higher spending per year than children without medical complexities, about $25,000 a year compared to about $1,700 a year for healthier children. Again, on DME, for children with medical complexities, we found about $1,600 in spending compared to about $230 in spending for children without medical complexities. For commercial out-of-pocket spending, children with medical complexities have about $2,200 in out-of-pocket medical and pharmacy costs compared to about $400 for children without medical complexities. However, I'd like to point out that the out-of-pocket spending we're able to measure here does not fully capture all of the other costs that families may need to bear that are related to healthcare, but would not be covered by insurance. Just to give one example, most pediatric specialty and subspecialty care in Massachusetts is concentrated in the Boston area, and children with medical complexities often need those types of care. And there are costs associated with traveling to reach that care in Boston for families who live in other parts of the state, including transportation, parking, food, overnight lodging, and time off work for parents. Next slide, please. Looking now by provider organization, children with medical complexities make up about 3 to 5% of commercially insured individuals age 1 to 21 per organization, ranging from 2.8% at Boston Medical Center to 5.4% at Children's. I'd like to note that this is a little different than the earlier graph that showed children with medical complexities inpatient stay by hospital. This analysis captures the organizational affiliation of children's primary care providers, where the previous graph captured where they received inpatient care, and children may not necessarily receive inpatient care within their own system. Next slide. Lastly, on use of the ED, children with medical complexities, both with commercial and with Mass Health managed care coverage, are more likely to use the ED and have nearly twice as many ED visits per person than children without medical complexities. Additionally, individuals with Mass Health MCO and ACO coverage are more likely to use the ED than those with commercial insurance. Next slide. Here we have a summary of the key points we've talked through so far in the previous slides. Next slide. We'll now turn to what we heard in our conversations with stakeholders. We spoke with stakeholders to learn about areas beyond the health system or that interact with the health system that we are not equipped to measure, but that are an important part of the reality of families caring for children with medical complexities. Next slide. Many stakeholders discussed access concerns for primary and specialty care and related to the COVID-19 pandemic. For primary care, providers noted that caring for children with medical complexities is time-consuming, both due to children's high health needs and due to administrative complexity related to insurance benefit design, meaning that pediatricians who are equipped to care for children with medical complexities can only take on a few at a time as part of their patient panel. On specialty care, stakeholders noted that a shortage of pediatric specialists who accept Mass Health can lead to waiting lists and access delays, including a domino effect of delays in qualifying for other types of support. Several stakeholders cited long waiting lists for neuropsychological evaluation as leading to delays in qualifying for educational supports, for example. Likewise, many children with medical complexities require specialty and subspecialty treatment that, as we've previously discussed, is concentrated in the Boston area, which can present difficulties for families in other parts of the Commonwealth, especially when children have difficulty traveling or when families lack access to transportation. COVID-related access concerns included missed care due to caution about exposure, including in-person care as well as home health services. And providers noted that while telehealth has helped to fill the gap for many families, it's not appropriate for all children, nor is it accessible to all families. Next slide. Stakeholders also raised concerns about care continuity and coordination. On continuity, they described frequent changes or interruptions in parental employment, which can make continuity difficult for families with commercial insurance when specialists are covered by different plans or networks. Returning to the theme of administrative complexity, providers noted that benefit designs intended to reduce avoidable spending, such as prior authorization or eligibility redeterminations, can be burdensome for clinicians and can interrupt care for children. For example, we heard from stakeholders that annual eligibility redeterminations for diapers that children will need on an ongoing basis is time-consuming for providers and interrupts families' access to supplies. Likewise, stakeholders noted that families may resort to seeking care in the ED when children require more supplies than their plans cover per year. Several providers cited ED visits to replace tracheostomy tubes when children have gone through all of their covered tubes mid-year, for instance. Providers also noted that plans may cover DME at a frequency that would be appropriate for adults, but not for children, such as only covering replacement wheelchairs every few years, even though children will outgrow them. On care coordination, stakeholders discussed families' need for what they referred to as an air traffic controller, a high level of coordination across health, educational, and social service systems, and agreed that this level of coordination would be appropriate at regional public health agencies. Next slide. Finally, both stakeholders and existing research discuss social complexities for families, including financial and social marginalization for parents who become their children's full-time caregivers, risk of poor mental health for parents, and other types of social complexity that become all the more challenging for families who are caring for children with medical complexities. Stakeholders noted that all of these types of social complexity can only make it more difficult for families to navigate the many health and social systems involved in caring for their children. Next slide. Next slide. We look forward to releasing a full report, including our recommendations, in the coming months. Additional topics we plan to address include hospital readmissions, pediatric to adult care transitions, ED boarding, behavioral health, and additional analyses related to spending. Be happy to answer any questions from the committee about our work. Thank you very much.
Thank you, Sasha. That was really terrific work and terrific presentation of it. Thank you. I have questions, but let me open it up to the committee. Why don't we form a list of who wants to make comments or ask questions? Stuart, go ahead. Yeah. Oops, wait, Stuart, I think, yeah.
Hi, Sasha. Good to see you.
Good to see you too.
All right. I didn't notice, maybe I missed it, whether you talked to the people at the floating at Tufts.
No, they were not among our stakeholders so far.
Okay, because they do run the second children's hospital, probably not as, clearly much smaller than children's, or maybe even partners, but I was just curious. But they weren't selected. Okay.
Sasha, let me ask you a question, then Marty, I'll turn to you after that. So Sasha, you didn't go through the recommendations a ton, and that's totally fine. I've wondered if one of our recommendations, I'd sort of been thinking about this, and then your presentation just kind of drove it home. One of the recommendations could be that EOHHS try and put together a kind of coordinating database for families. Like, I mean, it wouldn't be mandatory, but particularly for families that are receiving a lot of public services, because as you said, they're often disconnected, and the LTSS services will be different from the medical care services, and they're different from the social services and so on. And all of that and so no one is ever getting a like 360-degree look at the patient here and the patient's family and what they need. And so it seems like thinking about the care coordination aspect, the first element of that has to be to kind of put together a database that shares all that information about kids. And, we've spoken, as a commission, and of course the medical system has spoken a lot about the need to integrate care from different settings. And this may be like an ideal way to start off with that, because you've got a very high needs population where the family members are really complaining that it's not organized enough, and where a lot of the services, not all, but a lot of them are provided publicly. So it just seems like an ideal place to start, and it's a manageable number of people. So it seems like a great place to start to try and organize that together. So I'm wondering if that's a place where we can think of going on the recommendations.
Yeah, thank you very much. I think that's a really good point. I mean, one of the key areas that the legislature has asked for recommendations on is data collection. One of the points that was raised in testimony around the bill in which this report was included was the need for centralized data collection, so that families would know if they qualify for one program, would they qualify for another program, so that they don't have to do all of that legwork and research on their own. So that's a great recommendation for a place to start.
But I suppose what's coming in my mind is sort of along those lines is, at one point CMS in Washington created the Office of Dual Eligibles, because it said, look, these are the most expensive people. And, partly we deal with them in the Medicare program, and partly we deal with them in the Medicaid program, and partly we deal with them in social services, but we're never actually seeing all of them. And so here we are, 10% of people, and they're, some huge share of costs, and we're never looking at all of them. And so why don't we try and look at all of them? And so let's create an office that's just there to try and look at all of them. Now, I don't know how successful that's been at all, but that would be a kind of analogy here. Like, these are very expensive, very high needs. So let's create something to look at them as a whole.
Absolutely. Thank you.
Marty, and then I have Barbara after that.
Yeah. Thanks, David. Sasha, wonderful presentation. You really dug into this, and it shows. And thank you for the sort of reference to the continuing behavioral health needs of not only the children, but families as a result. So I had a question that sort of piggybacks on Stuart's, which was, did you capture pediatric nursing home care here, or long-term care facilities like Franciscan's Children's Hospital?
Not in our preliminary report so far, no.
Thanks.
I think on both of those points, both Chair Altman and Commissioner Cohen, we have an opportunity here that we're still working on the report. So absolutely open to suggestions about others who we should talk to and consult with as we continue to work on this.
Yeah. One additional question, David. I love the air traffic controller idea, but you reference regional public health agencies. Tell me what those are, because I don't think we have those.
Sasha?
Yes, I mean, that was something that came up in stakeholder meetings, that we used to have a more robust regional public health system than we currently do, and that would, this were it to be more robust again, this would be a valuable role for it to play.
Thanks, you made my point.
Barbara, please.
Thank you, David and Sasha. Let me just add how appreciative I am of the detail that you provided here. I'm going to swing back to two things. One, something David Cutler said about looking at how we create a systematic way of seeing the whole and responding to the whole. And if that requires a systems level organizational structure to consider that, perhaps that needs to be a major reflection on our part. I hate the thought of adding new organizational structures. I'd like to try to find existing structures that might be adapted to doing that work, but I absolutely agree with David. The more complex the patient, the more demanding of coordinated care there needs to be. I can tell you hundreds of examples of patients and families that just collapsed under the pressure of trying to coordinate everything plus live their lives. The second point I'd like to make is to swing back to the whole behavioral health issue, especially as we look at children, and especially given the pandemic and the isolation that children have had the last 18 months. There are now long waiting lists for children to get counseling in situations where they are literally at risk of slipping into suicidal ideation. We've seen that. We've got anecdotal information on that. I believe we've got academic numbers pointing to that as well. It is an emerging behavioral health crisis for adolescents. So as we look at this next phase, whatever you can investigate and whatever thoughts you can bring to the table to help address this issue, I think is vitally important. So I would just support the encouragement of you continuing to look at the behavioral health issues, both in light of the pandemic and what's happened to kids, but then beyond that, as to what the needs are going post-pandemic. What did we see before the pandemic? What do we expect to continue? What do we expect to be exacerbated because of the result of the pandemic? So obviously this could be a report unto itself. But if you could take a stab at that, that gives us the foundation to take the next steps. But we've got to come up with some policy recommendations that get more clinicians to more kids faster. So thanks.
Absolutely, thank you. Yeah, and one of the things that we've encountered in our work so far is that in addition to all of the challenges that you've laid out, there's another sort of layer of difficulty for this particular patient population, because they so often have both complex medical or mental or behavioral health needs and medical needs, and both in inpatient medical and inpatient psych settings are not always set up to support the other type of health need. So yeah, thank you for your comments. This is such an important topic for this group of children.
David, Seltz, and Colleen, I'm wondering if you can help us understand a little bit more about what the legislature is looking for. That is, do they think, oh, we have real big problems here, we need some advice on what to do? Do they think we don't even know the scope of the problem? Like what was a little bit going through the legislature's mind as they asked us to do this?
Sure, absolutely. And I think, Sasha, you listened to some of the testimony for when this bill was being proposed. So I appreciate you weighing in here too. But I do think that part of this was really trying to scope and understand this population for the first time. How many, where do they receive care? What are their diagnoses? What are their demographics? And so I think, as Sasha has really expertly laid out, I think we've been able to do that first part. But I do think that it was more than just a counting exercise. It was more to then try to understand where are the real barriers to care and access, the continuity of care, some of the things Sasha mentioned in the stakeholder conversations that, they're looking to us to be able to have some of those conversations, to identify where those areas of opportunity may be, and either for future legislation, for future appropriations in the state budget, future initiatives. And so, I think it was both a kind of a research project, but also, as many of our reports are, also what are the policy implications of this? But Sasha, why don't you add a little bit more color? Because I know that you have listened to some of the sponsors of this bill talk about it.
Thank you. Yeah, exactly as Director Seltz said, the legislature wanted to both just sort of get their arms around this population, because they had heard so much about the challenges of families and the challenges that children face in the Commonwealth. And so part of it was just, we recognize that this is a problem, but we need to know more about what's happening here and who these kids are. And then building on that, the need for centralized data collection to support, as we've mentioned, families knowing when they qualify for multiple public programs, to better identify gaps in services so that kids can receive care in a more timely fashion, to support better care coordination so that kids either don't receive duplicative care or don't miss care that they need, to better make our system, a little bit more centralized, a little bit more coordinated for these kids who touch so many parts that would not otherwise have reason to overlap with each other.
Do we have any other comments from or questions from commissioners? If not, let me ask where, how do we proceed from here?
Yeah, so we are hard at work on these additional areas of analysis, among others, to have a more fully fleshed out, a more complete report back to the legislature, and we're aiming to have our final report with full data, full descriptions, full recommendations in the coming months.
Sounds great. I think we will look forward to seeing more and potentially coming back some more to some of the recommendations. I know Marty is going to be interested in the setting up of the community care centers for people.
Thank you.
Thank you very much. So I think we want to turn to the policy recommendations part. David, shall I pass it back to you?
Yes, absolutely. Thank you. Thank you, commissioners. And thank you, Sasha. A great presentation and more to come on that topic. Part of our goal in presenting some of the preliminary findings today was to be able to get that out, in the public and to engage with a broader range of stakeholders and others. And so look forward to engaging with you on the report and the recommendations. But we're going to shift gears now, and we wanted to spend some of our committee time today returning to the policy recommendations that were included in this year's cost trends report and were the subject of a lot of discussion at our last board meeting. But we really wanted to dive deeper into these recommendations and to have further conversation with you commissioners about how we might further flesh out these recommendations, how we might advance them, and what type of research and data analysis would be most helpful as to make sure these things become a reality. I'm going to start with just the context here of why we are talking about enhancing the accountability of the benchmark and addressing excessive provider pricing, which is the two recommendations we'll talk about today, is because of the increasingly unaffordable healthcare in Massachusetts and the burden that places on individuals, families, and small businesses. So a lot of this we've talked about at the previous meetings, including discussion of the cost trends report, but total healthcare expenditures in Massachusetts did exceed the benchmark in both 2018 and in 2019, and commercial spending per enrollee was over 4% in both of those years. We see that this is causing affordability challenges that are worsening for individuals as healthcare spending outpaces wage increases, and an increasing number of middle-aged families, now up to 1/3 in Massachusetts, have more than a fourth of their earnings absorbed by healthcare costs, and that is an increase in recent years. And we know from survey work that CHIA does that nearly 1 in 3 residents avoided care due to the cost of care in 2019. Adding on to some of that work that we've done, there was a very recent survey that was done by the Alterum Institute of Massachusetts adults that found over 50% reporting an affordability burden due to healthcare costs, almost 50% here saying that they delayed or skipped care due to cost, and that these affordability burdens were much higher for Black and Hispanic identified residents. So on the next slide, this is the context in which we, and one more, the context in which we advance these policy recommendations at the board meeting. And so you can see the 5 recommendations laid out here. And we wanted to focus on the first 2 today, strengthen accountability and constrain excessive provider pricing. So we have a full presentation here, but again, this is really intended to be a discussion. So please jump in as you want, and we'll also hold questions to the end. But this is going to be a tag team presentation from our directors of market oversight and our director of research and cost trends. So Kate Scarborough-Mills and David Auerbach are going to walk through both of these recommendations, but we're going to start with Kate Mills on what we mean by strengthening accountability for excessive spending.
David, before you move on though, David, David, before you move on, one of the reasons why I've grown more concerned was the big increases in pricing in the end of 2020 and the early 2021, which sort of brings it more up to current numbers. I wonder if we could do some additional analysis of where we are in 2021 to make this problem more, as I said, more current.
Yeah, absolutely. So two things on that, Stuart. One is that the data source that we do use for that spike graph that showed at the end of 2020 hospital price increases, that national data is being updated almost on a monthly basis. So we can reach out to them and see if we can get a more updated version of that even into now 2021. So that's a great suggestion. Additionally, as we're preparing for the cost trends hearings, we are utilizing our requirement to have pre-file testimony to ask questions of health plans about what are the drivers of medical expense right now, and breaking that down by price, utilization, provider mix, and service mix. So that's a question we've asked before, but that will be able to give us some real-time right now information about what is driving healthcare spending costs. So we'll both have the retrospective and some new data to bear soon, but thank you for that suggestion. And Kate, why don't you start us off here?
Great. Well, thank you, David, and good morning, commissioners. We can actually go ahead and jump ahead to the next slide. So as David teed up, we wanted to use our time today to briefly reflect on the accountability framework for the state's healthcare cost growth benchmark vis-a-vis individual payers and providers as laid out in the statute, which is the Performance Improvement Plan, or PIPS process. I'm going to go through these first few slides pretty quickly because we've gone through this in the past, but wanted to make sure that we had a little bit of a reminder context for this recommendation, but do want to leave time for David Auerbach to go through some of the updated work on coding intensity in particular before we move on to a broader discussion of how the existing accountability framework can be improved. So moving on to the next slide. This is just a reminder of how the benchmark accountability framework as laid out in the statute works. So first, after we set the benchmark every year in step 1, CHIA then collects spending data from payers in step 2 to assess health status adjusted total medical expenses for payers and for primary care groups, which we'll discuss a little bit more in the next slide. And then in step 3, CHIA then assesses the growth in health status adjusted total medical expense for payers and providers. And consistent with the statute, which requires them to use growth in health status adjusted TME, it then applies a bright line test to determine a set of payers and providers to confidentially refer to the HPC for review and a potential performance improvement plan. In step 4, the HPC then conducts a confidential, robust, multi-factor review of each referred payer and provider across many different metrics and over time. And in step 5, the board can vote to require a PIP for any payer or provider for whom it identifies significant concerns and for which it finds that a PIP could result in meaningful cost-saving reforms. And then finally, in step 6, the entity has to propose the PIP itself with a maximum implementation timeline of 18 months and is subject to ongoing reporting and monitoring throughout implementation. And until a PIP is actually required, the review process and the identity of the referred entities remains confidential. And as you'll see in step 6, there is a provision that allows for a fine of up to $500,000 to be imposed for non-compliance, but it's really kind of envisioned to be a fine of last resort. Moving on to the next slide, a lot of this process really turns on the measure of growth in health status adjusted total medical expense, which, as I said, is by statute what CHIA is required to use in determining the payers and providers to refer to the HPC. So this slide summarizes that measure in a bit more depth. We've talked about it before, but as a reminder, TME is a measure of all medical spending for a given group of patients that goes through the claims system. So for payers, this is all medical spending by their insured members, such as prescription medications, hospital spending, physician office visits, and it includes both what the payer is paying and the patient cost sharing. But for providers, this is all medical spending by their primary care patients, regardless of where that spending occurs. So this means that primary care providers are accountable for the spending of their patients at hospitals, for example, regardless of whether the primary care provider is affiliated with the hospital in any way. But on the flip side, it means that hospitals are not directly accountable for the spending for their hospital patients, particularly if those patients have PCPs that are affiliated with outside systems. The TME figures are then divided by a risk score, which is calculated based on things like the age and sex of patients, as well as diagnostic information that's coded by providers to calculate a health status adjusted TME figure. And then, as required by statute, it's this growth in health status adjusted TME that can result in referral to the HPC and a potential PIP. And specifically, CHIA refers to the HPC entities who meet either of the two bright line tests that you see numbered here as 1 and 2 at the bottom. But as highlighted in the orange box, it's really important to recognize that high unadjusted spending growth, high levels of spending, or high prices cannot trigger referral alone. You really have to have some growth in health status adjusted TME above these bright line thresholds in order to even be referred into the process. As summarized on the next slide, we've been working with CHIA, the HPC and CHIA have been working together to implement this process now for 5 years, and it does have some real strengths. Overall, the agencies are working very well together to align processes, and the process has improved over time, including efforts to speed up some of the data lag issues that we've discussed in the past. The HPC's confidential in-depth review has also really been able to tease apart a lot about individual payer and provider spending performance, and we've found that payers and providers have actually been great partners in the process and in understanding their spending trends, and in some cases have actually expressed appreciation going through the process that it's allowed them to better understand their own performance. That said, as you see on the right side of the slide, the accountability framework does have some key limitations, particularly relating to the statutory requirement that HSA TME growth be the trigger for referral into the process. First, and David Auerbach will speak to this more in just a moment, but risk scores have really been growing significantly in recent years, which masks the majority of spending growth in HSA TME measures for most entities, meaning that many entities simply aren't being referred into the process at all. Second, TME isn't the same as THCE, total healthcare expenditures, which is what we measure the benchmark performance of the state by. So entities can engage in activities that can drive up total spending in the state and can drive up THCE without impacting their TME much, if at all. And relatedly, HSA TME only exists for payers and primary care groups. So other parts of the healthcare system, including other types of providers like hospitals, can't be referred to the HPC through the process. And finally, that $500,000 last resort penalty is relatively low, particularly given the levels of spending in excess of the benchmark that we see for some entities. So I'm going to turn it over to David Auerbach to talk about some updated data about risk score growth and how that's masking spending. But before I do, are there any questions about the general accountability framework? All right, I think it's on to you, David.
Okay. Thank you, Kate, and good morning, commissioners. Okay, let's go to the next slide. So I'll talk a little bit about trends in risk score growth and direct implications of that for the PIPS process, as Kate just described. So in this slide, we're showing the 6-year trend overall for pretty much all the state in TME, which is showing that in the blue bracket on the side, TME growth has been about 23% for this overall 6-year period. But you can see in the yellow section, that's showing risk score growth over this time period has been about 15%, leaving HSA TME growth, which is what the PIPS entities in the payers are judged on, as only 7.6% growth. So essentially, you're taking the unadjusted spending growth on the right and subtracting off the risk score growth. So you're left with just about 1/3 of that actual spending growth remaining that's being used for the assessment in the PIPS. And I'll break that down in the next few slides. But okay, let's move on. First, just to talk a little bit about that risk score growth. This slide we've shown before, but it's showing 1 year less. From 2013 to 2018, we had about 12% risk score growth. And it's occurring for all of the payers as shown. And we've done a number of analyses to check to see whether there are any population-wide factors that could be explaining 12% risk score growth. And there really aren't. The aging of the population explains about 0.5% out of that 12. There's no major trend in the burden of disease. There's no change in life expectancy. And to kind of put that 12% risk score growth in context, that's as if suddenly almost 1 million Massachusetts residents showed up tomorrow with something as horrible as cerebral palsy. There's just no way that that's reflecting actual increase in health status of the state's population. And then on the next slide. So, and we've documented before that this is really about coding behavior. So then when you look at take those HSA TME trends and how does that play out in the PIPS process? This is showing an example of 2016 to 2019 total growth, and it's broken down by provider group. And you can see we're comparing here unadjusted growth in the blue bars with growth in HSA TME in the orange bars. And the point here, the orange bars are all lower and they're much lower. And when initially envisioned, I think the idea was clearly that, well, we don't want to penalize a provider group for having a worsening risk mix of patients. And if all that was happening was that sicker patients were perhaps being traded across provider group, you would expect those orange bars to be on average about the same as the blue, some above, some below, but the fact that they're all below is showing that that's really not what's going on. There's these general trends that we've shown. Risk scores are going up everywhere. Okay. And then on the next slide, we show an example using real data as to how that plays out in the PIPS process, as Kate was describing. So we've chosen from several years ago, where the benchmark was 3.6. And we chose a representative sample of 3 of the largest provider groups, and then the 3 large payers. So that makes 9 data points. And we looked for that year of growth. The unadjusted TME growth for each of those 9 payer provider pairs is shown on the left. And you can see 7 of them would have been over the benchmark and would have been referred to the HPC if referral was based on spending growth. But the risk scores grew over that time period so much that when you adjust for risk and get the HSA TME, all but 1 then fell below the benchmark. And so only one of those 9 would have been referred to the HPC. And we wouldn't have seen the others at all, and we didn't. And that's really the pattern that has been going on for years, as we note on the right. If you look at all the entities in that year, 47 had unadjusted growth above the benchmark, but only 17 after risk adjustment then were referred to the HPC. Okay, and on the next slide, we're just showing that, a lot of folks in the academic community thought that, well, eventually this trend has got to slow down. Those who are looking for increases in risk scores and coding will pluck the low-hanging fruit, and there won't be any more to get. And this is just showing that no, that really we don't see any evidence of that at all. And this is one way to show that, where we're showing the 4 severity levels of inpatient admissions over time. And the lowest level is the lowest severity and the lowest paid, of course. The highest level 4 is the highest severity and the highest paid. And you can just see those trends are pretty smooth and continuing from 2013 even until 2020, removing COVID admissions from that year. Okay. And so, so that's the trend and risk scores and the impact on the PIPS process. Turning it back to Kate to finish up this section.
Great. Thanks so much, David. So this final slide rounds out our conversation about the accountability framework for the benchmark. So as we've discussed, the framework only holds payers and primary care providers for their spending growth, and primary care providers are only accountable for their primary care patients' spending. But as you know, many of our primary care providers are corporately integrated with a hospital system. So some could argue that the PIPS process at least indirectly addresses hospital spending because a provider's primary care patients are more likely to use the corporately affiliated hospital system. And that's true to some extent, but on that point, we wanted to show you the graph on the right, that for all of the large hospital systems, and this is just an example from one year, but we've seen this across many different years, many different payers, many different hospital systems. For the large hospital systems, a sizable majority of discharges are for patients with PCPs outside of that system. And so the hospital isn't being held accountable for spending relating to these patients. Those outside PCPs are. So you see in the graph to the right, for example, that in this year, 80% of the discharges from Beth Israel Deaconess affiliated hospitals were actually those with PCPs that were part of other systems. And so those other systems, their TME reflected the spending at those hospitals, but it wasn't actually reflected in the data for BID itself. So relatedly, if a high-priced hospital or even a specialty physician practice gets referrals from outside PCPs, if it increases its volume from those other systems, that may have little to no impact on its own TME, on the TME of its affiliated primary care group. So similarly, price increases are likely to have a greater impact on the TME of other systems and total healthcare spending in the state, rather than the TME of the affiliated primary care groups. So this is a nuanced point that I wanted to just make sure that we made clear that that hospital spending is being reflected in TME, but it's not necessarily flowing back to the TME of the affiliated primary care group. And this all really speaks to the recommendation that the metrics used to identify entities with concerning spending performance be improved to ensure that the accountability can really flow to those entities who are driving the spending growth in the state. And a couple final points before I open it up for discussion. As mentioned, the statute provides for a last resort penalty for noncompliance of up to $500,000. That figure is relatively low, but it's particularly low given the levels of above benchmark spending that we see. So in a given year, we sometimes see that a single provider, their commercially insured patients may have spending growth in excess of the benchmark by tens of millions of dollars in just 1 year. Similarly, for payers, we see that a single payer's commercial members may have spending growth in excess of the benchmark by tens of millions. And of course, the PIPS process is not really designed to address one of the biggest drivers of healthcare spending in the state, provider prices, which is why we think that it's important to couple improvements to the benchmark accountability process with efforts to specifically address provider pricing, both to reduce spending growth in the state, but also to address some longstanding disparities, in particular around provider price variation. So we'll talk a lot more about provider pricing next, but before we turn to that, I wanted to just open it up for further discussion on the first cost trends report recommendation about improving the accountability framework for the benchmark.
Stuart, why don't we let you dive in?
Yeah, this is great stuff. Thank you, Kate and David. So I have a number of questions. First of all, I know, Kate, that when we see reports of individual groups, one of the things you do is to compare the growth in either the adjusted or the unadjusted to the growth, either in the benchmark or in actual growth in that year of overall spending. What I'm curious about is, and I have always been a very strong believer in the PIP process as one of the major tools that the HPC has to get at what's going on. But the more I understand it, the more concerns I've had, and the reason why these recommendations are really very important. So I wonder a couple of things. First of all, David, when you compare the growth in either the unadjusted or the adjusted, compare that to what happened during that year in terms of overall spending, not the benchmark, but the growth, and get a sense of whether these PIP measures are at all reflecting what's going on. Because when you look at the total for the whole state, you don't need to adjust. So I wonder what that looks like. Does that make sense to you, David Auerbach?
Yes, yes. And I think that the slide where we showed the larger provider groups and comparing the health status adjusted growth and the overall growth is maybe the best way to get at that. But I could also just break that down by saying, on average, the risk scores have been growing about 3% per year. And so that means that for the whole state, in a typical year, you might have about, let's say, 3% growth in unadjusted TME and about 0 growth in health status adjusted TME. It's about a 3 to 4 percentage point delta, if that makes sense.
That's what I think.
Yep, that's about where we've been.
The second related stuff is when I, many years ago, chaired ProPAC and began to look at these mechanisms for hospitals, and particularly hospitals, to upcode their DRG payments. I went to a few of these conventions, and I wandered around all the companies that were selling their products to the hospitals or to the health plans on how to upcode. They claimed legally. And I wonder whether we could begin to look at behind the scenes what's going on. I think your numbers are really, really good and important. A, how much there is, and B, that it's not getting less. But I'm wondering whether we could also learn by sort of digging in at a little bit about the consultants that are being used by both the providers and the plans to sort of increase their codes.
Yeah, we've looked a bit. It's hard to find hard data on this. We've looked a bit into the hospital cost reports, for example, and you can't really tell much from there. But we know a lot from, MedPAC has done a lot of work investigating this, but that's mostly in the Medicare Advantage context, which is a little bit different. There, it's more of a lot of it is similar and some of it is different. But we've looked a bit at this, but it's a bit hard to see. I know that Don has done some investigation into this too, and I don't know if David, if you want to comment on that as well. But.
Well, I was just going to add, I think it's a great suggestion, Stuart, to dive in a little bit more on this. I will reflect, and this is anecdotal, so not a rigorous data point. But we had conversations with a leader at one of our biggest healthcare systems a few years ago, and the reflection to us was that they were increasingly hiring more and more administrative staff to work on kind of quote unquote accurate coding strategies, and that the ROI for continuously hiring like didn't have an endpoint. And so the more you hired, the more that you could generate revenue. And in his work and analysis, that there was no peak. And so, I think there are other implications for some of these dynamics that go beyond what are our health systems investing in, and where are they putting their dollars that may not be clinical care staff. So an anecdotal reflection, but Commissioner Berwick.
Thanks. I missed the first part of the presentation. I apologize, but David, is there comparative data on other states? Are we looking different from other states, or the same, or we don't know?
That's a good question. Probably the best comparison is there was a recent report by the Office of the Inspector General at Health and Human Services that did a similar kind of analysis that we did on the severity of hospital patients. And our numbers look very similar to theirs. So that's probably the best comparison. Beyond that, there is more we could probably do in claims data, which we haven't been able to do yet.
Thanks. I just want to mention, as many of you may know, Rick Gilfillan and I published a 2-part blog in Health Affairs last week that it goes over a lot of this for the Medicare Advantage world. And it's interesting to crosswalk the two. They're very similar.
I'm wondering, David Auerbach, I'm wondering whether we think a better guide to true changes are coming from the unadjusted TME as opposed to the adjusted one. Like if we could only use one and we had to guess which one was truth, closer to the truth. Do you have a guess as to what it would be?
I do, yes. I think pretty clearly it would be the unadjusted. And we've heard this from our actuarial consultants as well, that what we have here is you have a fairly large collection of patients for these payers or provider groups. And even though at a point in time, they might have a different level of risk, this is all based on growth from year to year. And these populations just don't change that much from year to year. And so I think it's pretty much agreed that you're better off going with the unadjusted or maybe an age sex adjusted for this process. We've heard that from other folks as well.
And if I could just add to that, I want to be clear that we aren't saying that risk adjustment should be thrown out and that it doesn't have value. It's that growth in health status adjusted spending within a given provider or within a given payer really is very influenced by their coding practices. And we don't really see that much patient population change from year to year within a given provider network or a given payer network. Where health status adjustment is particularly important is, comparing two providers to each other. They may have different risk profiles. And so I think there it would be really important, but for a trigger into the process to have it be based solely on health status adjusted growth is potentially problematic for the reasons we've outlined.
Okay, why don't we go on to the next part of this?
Okay, shall I just take it away? Okay, great. All right, so now we're going to talk about the second recommendation, which is about constraining excessive provider prices. I don't know, did you want to say anything about this, David, before we move on? Okay, great. I think we all know what it is. And I'm going to show some national data, some examples from other states, and then talk a bit about implications for Massachusetts. Okay. Yep, I just said the outline there, and that's where we'll go. Okay, so this graph is showing growth since 2008 in comparing growth in private health insurance spending to growth in Medicare and Medicaid spending cumulative over time. And you can see this trend that we've all observed, that the private health insurance spending growth is really diverging. It's sort of running away from Medicare and Medicaid. And that's all about prices. There's not different utilization trends in Medicare and Medicaid. And this wasn't so much the case, 10, 20 years ago. And people are observing this. For example, commercial spending per hospital stay is growing twice as fast as it is in Medicare. And this price growth, as we've said, is more facility price growth than it is physician price growth, and that has been studied as well. So on the next slide, that sort of trend has been observed, and it has led to a growing number of states to take action and policymakers and think tanks to say, you know, we need to do something about this directly. And here we're relying on, and we'll talk about this a little bit, a report from March 2020 by Mike Chernew, Lumor Daphne, and Dr. Pani that was in the Hamilton Project, published about a year and a half ago. And as they say, while the United States will likely continue to rely on markets to allocate healthcare resources, overall market forces have not been sufficient to constrain commercial provider prices. And their approach would involve a rate cap on the level of prices only affecting those at the very top, and we'll get into that, coupled with a cap on price growth at the level of an insurer or provider. And they call for government oversight to address evasion, to monitor the process, to make sure that it's working well. And that's sort of their three-pronged approach. Other folks have weighed in on this, have estimated and done some simulations. For example, the Committee for a Responsible Federal Budget found that a hospital price cap at the level of 200% of Medicare, so double Medicare's rates, they found would reduce commercial premiums by 6%, by almost $1 trillion over the next 10-year period, and reduce cost sharing as well. Okay, next slide, please. So a number of states have already taken action, seeing the same trends, addressing the same problems as well. And I'll go through some of these. A couple of them, Montana and Oregon, and Rhode Island is perhaps the most important one that's been around since 2010. I will get back to Rhode Island and spend more time on that. But even in the recent 5 years, Montana and Oregon, through their state employee plans, decided they were going to limit how much they pay hospitals as a percentage of Medicare. Montana, somewhat famously, set their limit at 234% of Medicare rates, and that is a limit that applies to the overall hospital average. In Oregon, interestingly, their Medicare limit, which was 200%, applies service by service. That's an important distinction to think about as we move forward. A number of other states, Washington, Colorado, Nevada, have used a Medicare rate cap for their public options in their exchanges, 160%, 155%, and with some additional requirements to make sure that they still do have adequate provider participation. And just this year, even just very recently, Delaware implemented a growth cap similar to Rhode Island's, of a cap on hospital prices can only grow at a rate of CPI plus 1 percentage point. And on the next slide, I'll talk a little more about Rhode Island. Way back in 2009, their legislature passed a package of standards that had a few things at once. And some of these are pretty well known. They mandated an increase in the percentage of all spending that goes to primary care. And at the same time, they placed a constraint on growth in hospital prices. And they also required that hospitals all use DRGs, which in Massachusetts, that's pretty much mostly true today. Their cap on growth said that hospital inpatient and outpatient growth combined from year to year could be no more than CPI. At first, they used Medicare's hospital update factor. They later switched it to general inflation plus 1 percentage point. So for example, in 2017 to 18, 2.7% was the price growth limit for hospitals. And the way they do that is it's through their rate review process that is monitored by their Office of the Health Insurance Commissioner. And what they do is a payer submits to them their average price increase for a given hospital. So think of, one payer, one hospital, averaged overall for all that hospital's services. And they say, this is the weighted price increase that hospital is going to have for the next year. And that is the thing that can't be over 2.7%. Okay. And so fortunately, that was 10 years ago for us, and we've been able to see how that program has worked out. So the next slide is summarizing some of the results for a study done a couple of years ago that was published in Health Affairs. And what they found was that absolutely worked to the goal of reducing overall spending. And what they're showing here in the main finding graph is Rhode Island spending, fee-for-service spending in total per enrollee in the blue. And they compared that to a number of control states in the orange. And they found that Rhode Island spending initially was higher than the control groups. And then after a couple of years where it took to implement this law and I guess get everybody to understand it and see how it was working, that blue line passed below the orange line by quite a lot. And by 2016, fee-for-service spending, total spending in Rhode Island was 15% below the control states, which, approximately what Rhode Island would have been. So you can think of that as a total change. And most of the savings, as they analyzed deeper, where were those savings coming from? And as expected, it was almost all coming from spending, from hospital spending, and it was from a reduction in spending per visit. There was no change in the number of hospitalizations. They also found cost sharing dropped, and a couple of investigations of quality of care, they found no change, and they found even one low value care measure improved over time. And that led them to conclude that those measures effectively leverage state regulatory power to reduce healthcare costs, particularly in areas where the market power of the providers is greater than the insurers. And the next slide just emphasizes that point of, but the reduction really came through lower spending per hospital stay. And that's what this is showing, Rhode Island in the darker blue circles below, passing below spending per hospital stay for the control groups. Okay, and the next slide. So now shifting back to Massachusetts and what we've been seeing, the price trends are the same. We've shown this before. Most of the spending growth in Massachusetts has been through prices, not through utilization. HCCI recently updated just yesterday their findings through 2019. It's the same. It's about 5-to-1 prices to utilization nationally. And when we look, this is in our cost trends report, the price increases are higher. We're highest in the hospital inpatient, and then 6.6% in the outpatient, and then less, but still growth in the office-based services. Next slide. And we have also shown this slide before, but just to emphasize on the inpatient side, you can see that the volume has been dropping and then flat lately. That's the orange, the number of commercial inpatient admissions, while total commercial inpatient spending in the blue has grown. And what that amounts taken together is about a 5.5% annual increase in commercial spending per hospital stay. So that is a combination of price increases and coding increases pretty much. Okay, next slide. Now we wanted to try to put in context that Rhode Island growth limit of 2.7% in 27 to 18. How does that compare to the kind of price growth that we've seen in Massachusetts? We don't have the exact kind of data that's used in the rate review process, but when we look in the aggregate, how much did spending across all of inpatient grow in Massachusetts in 17 to 18? It was about 4.2% total. When you include facility and professional, it was about 4.5% if you look just at facility. So in aggregate, it was over that Rhode Island limit. And in the hospital outpatient side, again, it was less over that limit, but still over the 2.7. So most likely that Rhode Island limit would have had some impact on Massachusetts. And again, this is looking backwards. It's not quite the same as a rate review where you post your rates and that's looking forward. So it's a bit different. Okay, on the next slide, I want to make sure we get to some of the issues of the cap on the level of prices, which is different from growth. And as we know and as we've seen, they're different. And if you only capped growth, you would still preserve and perhaps make even worse the price disparities that we see. And those are problematic and those are important. And in the Hamilton Project, they again argue for both. Capping price levels can reduce the impact of provider market power while allowing prices to remain flexible beneath the cap. And as we have seen, the disparity in price levels leads to this unending cycle where certain providers are able to capture higher commercial prices. They invest that money back in facilities and other things that in some way are designed to attract more commercial patients and enhance their market power, and then perpetuate and increase the cycle at the expense of those hospitals and community hospitals that have lower prices. And on the next slide, we'll show just a little more about the extent of price variation. We've shown this before. Average prices on the outpatient side by hospital vary about 3-to-1. And on the next slide, on the inpatient side, it's a little bit less variation, but it's about 2 to 1. And you can see the same kinds of patterns by type of hospital. Okay. And just to note that price variation has not improved over the 10 years. And that's, again, a reason why we really need something to act on the level of prices. This is showing relative prices just for Blue Cross as the payer, and each hospital is a dot. It's about the same from 2010 to 2019. And on some measures, price variation is getting worse. We saw that the percentage of discharges from hospitals with prices 20% above average grew from 23% in 2015 to 27%. So more and more discharges taking place at the highest price hospitals. And the percentage of payments as reported by CHIA at these in the top hospital quartile grew from 51.9 to 54.3. Okay, so more concentration at the top. Next slide. So we wanted to explore a little bit about how a cap at the top level of prices might interact with what we know in Massachusetts. This is an example from colonoscopy, and we've just arrayed the prices, all the prices paid for all colonoscopies that we see in the APCD in 2018. And they were arrayed by relative to Medicare. What were the prices that they were paid at? And in this example, we're showing a line at 200% of Medicare to 50% of Medicare. We find that about 21% of encounters were paid more than 200% of Medicare in that year. And if, for example, you capped prices at that level, then colonoscopy spending would be about 5% less. In the next example, we're showing a similar idea, but for hip and knee. And so if you look at where 200% of Medicare would fall based on what was paid in Massachusetts in 2018, you find that it's a bit different. You could do this a number of ways. You could use the base Medicare rate, which doesn't include teaching, doesn't include DISH. In that case, you would find about a quarter were paid over 200% of Medicare and a 5% reduction if that was the limit. If you include disproportionate share hospitals, if you include teaching and so on, then of course it would be less of an effect. 12% would be over that level and spending would be reduced by 1.7%. It's just a flavor of the kinds of analyses. And we're really just starting at the tip of the iceberg here. Okay. And on the next slide, just to talk about, again, the Hamilton proposal talked about using private rates. And they talked some about where those might be set, for example, and they chose kind of a weird benchmark, but they're like, look, you can do whatever you might want here. And they argue that a private-based benchmark, so where you're just using some factor related to the distribution of private rates in the market, they say that would be more influenced by local market conditions than a Medicare nationally based benchmark. And you could make arguments for why that's better or for why that's worse. But many states, as we showed, do use Medicare. And just a note about that, Medicare's rates are designed to be about what costs should be. And MedPAC's recent analysis showed that in 2019, Medicare payments for an efficient hospital was right about what their cost was. And for other hospitals, Medicare was about 7% below their cost. So think of Medicare rates as within 10% of a hospital's cost, which means that 200% of Medicare-based benchmark is about a 90% markup over cost. That's about what that payment would mean, just for context. And another thing about Medicare rates, Medicare spending per enrollee in Massachusetts grew 2.4% per year from 2016 to 2019. So Medicare's growth adjusts based on their approximation of what costs should grow for a hospital. And that gives you about 2.4. Commercial spending per enrollee in Massachusetts was about 3.7, so over the benchmark. Okay. I think that's really all for the content slides that we have. Let's look at the next slide. I want to leave room for discussion, but I'll just note that we are continuing to research what are other states doing. We want to know about the implementation, how they're doing it. We want to understand what are the implications of different benchmarks? How does coding interact with some of these ideas, with some of these processes, and understanding our own growth better in relation to where these caps might be.
David, does the Medicare growth figure include MA or is it just traditional Medicare?
Those figures that I showed for Medicare, I think those are pretty much mostly just fee-for-service Medicare. Are there any other questions?
So David, there's no reason why the proposal couldn't be different at different types of organizations, right?
Right, there's no reason. I mean, I'll note that I believe someone might help me on this, but I think there was an administration proposal a few years ago that would have pretty much, I think, grouped hospitals by their relative price level and said, we'll have different allowed rates of growth based on where your prices are today. And I think that was an interesting proposal that I know Kate's team spent a little time thinking about. Yes, you could do anything like that. Yeah.
Could I ask a question, Dave? Historically, when the commission was set up, why were hospital expenditure levels not included in the commission's purview? Why was it restricted to primary care and plans? Does anyone know the history of it?
So I'll give my perspective, but then David Seltz, please feel free to add. I mean, the total medical expense data that is used for the PIPS process was considered and still is considered to be a wonderful measure that captures utilization and price together, that comprehensively looks at the total spending for a patient population. So it incorporates, whether or not the patient is using higher or lower cost drugs, whether they're using low value care. So there are some wonderful things about the TME measure. We don't have a comparable measure yet on the hospital side, and so I think one of the reasons may simply be that there wasn't a comparable measure that already existed, whereas TME had been collected for a number of years by CHIA already at that point. At that point, the Division of Healthcare Finance and Policy.
And to add on to that, I think the recommendation and the ask really of the legislature here is to just remove the requirement that HSA TME be the sole metric for referral into CHIA. And that was proposed in legislation by Governor Baker as part of his healthcare plan prior to the pandemic. And that will provide our regulatory agencies the flexibility to determine what metrics may work best for different types of provider organizations like a hospital. And so the development of that would be one that would, of course, be collaborative, would bring in stakeholders, would take some time. But right now, we can't even go down that route given the statutory limitations and requirements.
I think there's a sense in which this relates to the previous discussion in that the TME metric makes a lot of sense if the systems are not so overlapping. If the primary care physicians from one place refer to the specialists at one place and the primary care physicians at place B refer to the specialists at place B. And so they're kind of teams like that. And what we've discovered is that, in fact, they're not that separate. That is, if you get very sick, you wind up going to the big, expensive places, regardless of where you started out. And that's bad because that makes life difficult, because now you have the situation where primary care physicians from around the state are all supposed to be beating up on the super specialized experts, which they are. And so they're just not able to do that well. And it also is the situation where a lot of the revenue coming into the very expensive specialized places is still coming in on a fee-for-service basis and stuff. And so I think that crossover is really, I don't know how different it is from other markets. My guess is we're much more in that way than other markets are. And I think that's been a really big issue and means that we have to think about some other possibilities in addition to just putting the onus on the system involving the primary care doctor.
So I hate to make what is a very complex set of issues even more complex. And particularly given the discussion we had before about how the risk adjuster is becoming messing up all of our statistics. But I want to throw out something that that we should look into, which is if you go to the state of Maryland and its longstanding total spending constraints and controls, it does make adjustments for some aspects of hospital more than just their patient care, including research and teaching. And I know it makes it on the level. I'm not sure what it does on rate of growth. And David Auerbach, I wonder if we could look into Maryland a little more and see to what extent they believe it's appropriate that there be some adjustment to these numbers based on some of these other aspects, whether it's research and I bring that up because I don't want any spurious arguments thrown at us by the high spending, high pricing institutions that really it's unfair to compare us to the ones on the bottom because we do X, Y, and Z. And I'd like to, if we could find some adjustment and then make the adjustments you're saying, I think it would strengthen our case.
Great.
Does that make some sense to the team here?
Yeah, we have done some looking at Maryland, and there's more that we could understand and talk about in that context for sure.
Tim?
Hey, great work, everyone. Appreciate all the work that's been put into this and continuing the conversation. Just on this focus of next steps, clearly we have the cost trends report and the policy recommendations that we put forward that are very broad. Clearly, we're looking at some next steps to further refine. Is the goal to come up with actual policy recommendations that meet kind of the broad goals that we put forward and submit that to the legislature? Like, are we trying to hone in on a specific recommendation for legislative action for each of these areas, or a menu of options? And what does that look like in terms of board involvement, like next steps? And will there be a recommendation for a vote that this is what we want to submit to the legislature as things that the HPC believes needs to happen to address the concerns raised in the cost trends report? Just trying to understand the process. Are we looking to refine specific recommendations from the broad policy outlines we put in the cost trends report? Thank you.
Yeah, thank you, Tim. And I think I think we're open to a conversation about that. I think our goals was really to dive a little bit deeper and be able to bring kind of our data and research expertise to the implications of the recommendations and to further provide information into the public space and to policymakers about, what are the considerations for setting different types of benchmarks? What are the considerations for setting different types of caps? And so, I viewed today's meeting as really just another in a series of conversations with the board and with all of you as we kind of further dive deeper into these recommendations and what the policy solutions may be. And this was a tee up conversation today. We'll also have the cost trends hearings coming up on November 17th. And that will provide an opportunity to engage directly with leaders of our healthcare system on this as well. But I do see this as kind of an iterative work stream, Tim, over the next couple of months where we're really going to be able to dive more deeply. And, if the commission, through that investigation feels strongly that they want to take a position, kind of a clarifying position on our recommendations, I think that could certainly be on the table. But I think for now, we're really trying to use data and research to understand the implications and considerations and what other states have done.
I think using the cost trends hearing as an opportunity to get reactions from stakeholders about some of the potential policy recommendations or further research to see the reactions to it would be an interesting and important conversation.
Yep. So thank you for this conversation. We're 5 minutes into our next committee meeting, but I just want to thank the commissioners for all of your comments. Colleen, I think we're going to try to squeeze in a quick break and reset, but we'll be still in this Zoom room. Colleen, do you want to tell us what the plan is?
That's really the whole plan, David. We're just going to take a 2 to 3 minute break. Feel free to put yourself on mute, stop your video, and then just come right back here to the Zoom room, and Barbara will take us away. Thanks, everyone.
Thank you. I, for one, need more coffee.
Okay, we are adjourned then. Thank you.
5.
Great. Good morning, everybody. And for those of you who are continuing on, welcome back. And for those of you who are just joining us, we're glad you're here. We're going to get started with a review of the minutes of our last meeting. And let me first call for, are there any additions, corrections to the minutes? Okay, hearing none. Colleen, I believe we need to do a roll call.
Absolutely. I'll just ask for a motion first.
Oh,
Yeah, motion.
And call
Thank
for
you.
a second.
Second.
Great. And I'll start with you, Madam Chair.
Approved.
Commissioner Cohen,
Approved.
Commissioner Kreider. Might have just stepped
Yes.
away. A
No,
present.
I'm here. Yes.
Okay. Thank you so much. And Undersecretary Peters.
Approved.
Thank you so much.
Okay, then, thank you. And sorry, I'm working off my cell phone here. Let's begin with some very exciting discussion, and I'm going to turn to Kelly, who is the Senior Director for our healthcare team. And Kelly, why don't you lead us in this?
Thank you so much, and good morning, commissioners. So let's get started. As many of you may know already, the process for certifying ACOs for the 2022 cycle is currently underway. But even as we see that process through to conclusion, we have kept our eye on a longer-term goal of integrating performance into our certification program. My colleague, Mike Stanek, is here today, along with Catherine Harrison, to share some early thinking on how to do just that. So with that, it looks like we're already into the slides, so I will turn it over to Mike.
Thank you, Kelly. Good morning, commissioners. As Kelly mentioned, today I'll be walking through some ideas that our team has for incorporating a look at performance transparency for our HPC certified accountable care organizations. Please feel free to jump in with questions as we go, but I do intend to reserve some time for questions and discussion at the end. So I want to start with a brief refresher on our team's work with ACOs. The ACO certification program has been in place since 2017, and we've completed 2 application cycles to date. Certifications are effective for 2 years at a time, and we're currently in the midst of our 3rd application cycle right now. At this point, 16 ACOs, comprising some of the largest health systems in the Commonwealth, are certified. Together, these ACOs span the Commonwealth and collectively have around 2.9 million patients attributed to them under risk contracts. The ACO certification program supports the agency's care delivery transformation goals by setting forth a set of multi-payer standards. These standards are applicable across an organization's risk contracts, be they with commercial payers, Medicare, or Mass Health. We work closely with our partners in state government, particularly Mass Health, to ensure alignment. And overall, our standards attempt to complement other standards or requirements that may exist in the market. Beyond setting standards, the ACO certification program also seeks to advance knowledge and transparency about ACOs in the Commonwealth, as well as facilitate learning across the delivery system in Massachusetts. We further these aims primarily through the HBC's learning and dissemination function. And we've seen quite a bit of variation in how ACOs conduct their operations and pursue care delivery transformation. You'll recall that this year we're updating our certification standards to incorporate more flexibilities than in the past, and to focus on structures, processes, and approaches that are conducive to learning and improvement over time. We're calling the updated standards Learning, Equity, and Patient-Centeredness, or LEAP, 2022 to 2023. And the application period for LEAP certifications is now underway. Next slide, please. Historically, our certification standards have largely focused on ACO activities and approaches. In the past, we've looked at ACO governance, including consumer representation therein, quality improvement approaches, population health management programs, and cross-continuum care connections. As I mentioned, this year we are implementing updated standards, our LEAP framework. These standards focus on activities and structures most likely to facilitate learning in ACOs over time, such as data-driven decision-making practices and organizational cultural commitments to performance improvement. You can see here an example of a typical criterion from our new LEAP framework. This one looks at initiatives, supports, and/or analytics that ACOs are offering to providers to support high-value data-driven care delivery. You'll note that here we're looking at what ACOs are doing and how they're doing it. This approach to certification reflects where the evidence base in the market have been at and where they are at this point. And we felt that it's appropriate to focus on these sorts of structures and activities since the ACO is an organizational model, and a key premise of the model is that performance will ultimately result from a mix of new incentives, structures, processes, attitudes, and culture. Next slide, please. But beyond considering ACO activities, the HPC has long been interested in finding ways to examine and perhaps recognize ACO performance. Some examination of what ACOs are achieving with respect to cost containment, improvements in quality and patient experience, and health equity is important to the vision that we've put forth for the direction in which the certification program will evolve in the future. We're interested in finding ways to make connections between the structures and processes we encourage in our standards and actual outcomes achieved by ACOs. We've said in the past that we're interested in furthering understanding over time of how ACOs achieve improvements in performance on quality, cost, or patient experience, and that we'd like to in some way recognize the performance that ACOs are achieving. In that vein, we'd like to learn from those ACOs that have achieved significant improvements or are performing especially well. We view this as an important component of the program's transparency function, as well as a potentially ripe area for our learning and dissemination objectives. As we'll talk more about in a moment, we have in the past, and we continue to think about ways to pair the certification standards with some examination of ACO performance. Next slide, please. You may recall that we have previously put out a high-level framework for an idea we were calling ACO Distinction. This would have been a recognition available to HPC certified ACOs. They could voluntarily seek this recognition, reporting supporting data directly to us at the HPC, and showing a level of performance improvement over time in measures of cost, quality, access, and health equity. There would also have been a component to this approach in which ACOs commit to a strategic plan for continuing to improve performance over time. We released this framework publicly, and we received a fair amount of feedback and public comment, which we reviewed at a previous CDT committee meeting. Stakeholders urged us to take a deliberative process for designing such a program. This included an extended timeline for development, clear statement of the purpose of creating a distinction program, and the measures that would be included, as well as any criteria or methodology used to determine distinction. Stakeholders also expressed interest in any incentives that an ACO would have for pursuing the distinction recognition. We also received comments cautioning about the challenges of reporting performance information to us, as well as some comments urging alignment with measures that ACOs are working to improve. So we took that feedback to heart and took a more deliberative approach, and much of our bandwidth turned to updating the certification standards and designing the new LEAP framework. But I did want to acknowledge here that this idea has been put out publicly in the past and has been percolating within our team for quite some time. Next slide, please. More recently, we've returned to this general concept of considering ACO performance, and we've tried to look at it with fresh eyes. With the launch of the LEAP standards, which draw so heavily from the idea of a learning health system in which ACOs are working to innovate, learn, and improve, it made a great deal of sense to think about how we might do some complementary examination of how certified ACOs are performing. You can see the three general types of approaches that seem feasible to us. First is a transparency-only approach, which is the simplest. This would involve compiling information on select performance measures and publishing it in an HPC output. The goal here would be simply to make this information about the certified ACOs easily available, but no designations or recognitions would be awarded based on this information. The other two options involve the same process of compiling and publishing information on performance indicators, but would take a step further and provide recognition to noteworthy ACOs. This recognition could be either on the basis of notable improvement on the metrics displayed over some time period, or the recognition could be on the basis of overall absolute performance. Next, please. Where we've landed, as we'll discuss in more detail shortly, is a combination of the first and second approach shown here. Next slide. A number of factors guided our thinking as we considered those three general approaches. We want to ensure that whatever we do advances the transparency goals that are core to the certification program, as well as our learning and dissemination aims. At the same time, we want to avoid creating any new administrative or reporting burden for the ACOs at this time. Our prior thinking on a potential distinction program had contemplated new voluntary reporting by ACOs. However, this principle has pushed us in the direction of relying on performance data that is already collected and publicly reported by other agencies like CHIA, CMS, and Mass Health. That will allow us to consider and publish on all certified ACOs and better aligns with the HPC resources available to this work. In line with our goal of avoiding the creation of new reporting requirements for ACOs at this time, we considered the data available for this sort of performance transparency approach. And at present, a fair amount of data is publicly available from entities like CHIA and CMS. We also want to acknowledge that payers and purchasers do tend to have their own data collection and evaluation approaches in place to track and incentivize quality improvement. Our goal here is not to replicate or duplicate any existing accountability mechanisms in the market. Our interest here is primarily in greater public transparency. We also want to make sure we're striking a balance between a manageable, streamlined measure set and a meaningful snapshot of an ACO's overall performance. And finally, to the extent we can, we'd like to dovetail with our new LEAP certification framework. Next slide, please. I want to pause here before getting to our proposed approach to provide a quick reminder about a learning and dissemination output that the HPC regularly releases based on information that's reported in the ACO certification application. This output is a collection of what we call ACO profiles. And what's displayed here is the general outline of those ACO profiles. You can see that we currently share a brief description of the ACO's organizational structure, some information about its risk contracts and general characteristics, and a map of its service area. Because these profiles have become a central vehicle for sharing information about ACOs, and each ACO's profile is updated every 2 years, these profiles are potentially a natural place to incorporate additional information about ACO performance. Next slide, please. Under the original distinction concept we had put out, there would have been an administrative burden for ACOs opting into participation. Without clear payer incentives for ACOs to opt in, we felt it makes sense for us to pivot our approach a bit. Instead, under our proposal today, we here at the HPC would be doing more of the work, but recognizing performance outcomes in a way that achieves our goals. This will allow for greater ACO participation by removing barriers that came up during the public comment period for the distinction idea. What we're proposing today is to implement a two-phase process. We'd begin by pursuing what I called the transparency-only approach, in which we compile and publish publicly available performance data for the certified ACOs. This would likely be in addition to the HPC's ACO profiles, and we think it would add some important context and information to the other data published in those profiles. This transparency phase would give stakeholders and us here at the HPC a chance to get used to collecting this information, again, from publicly available sources, and publishing it. We see this transparency approach evolving over time as we gain experience with it and as data resources and measurement evolve. In the second phase, we would continue this important transparency function, but layer on some acknowledgement of how performance is changing over time, particularly via some recognition of those ACOs that have seen improvement on the most tracked metrics. And we've had some preliminary conversations with our colleagues at Mass Health and CHIA about this proposed approach. And at this stage, we do have their general buy-in for this concept. And we continue to work with them to make sure that we're aligned with respect to sharing and using performance data. Next slide, please. Here you can see the general timeline we have in mind for this two-phase process. I'll explain a bit how this relates to the ACO certification cycle. Almost all of our certified ACOs are on the same certification cycle. They apply at the same time, their certifications are effective at the same time, and they're certified for the same 2-year period. For the bulk of the ACOs, they apply to us at the end of odd-numbered years for certifications that go into effect at the start of even-numbered years. And so that means that every 2 years, 2022 being the next such opportunity, we have a new cohort of freshly recertified ACOs. At that point, we can transition into doing any learning and dissemination work that comes out of the recently concluded certification process. And so, for example, our batch of ACO profiles tends to get a full refresh at that time. So you can see here that we would spend the next few months identifying our initial slate of measures to incorporate in the next refresh of the ACO profiles next year. As I've mentioned, we've already had some preliminary conversations with our colleagues at MassHealth and CHIA, but we would certainly continue to consult with them as we work to firm up our measure slate. This set of activities will be happening as ACOs are in the process of applying for certification under the new LEAP standards, since we're currently accepting applications for certifications through the end of the calendar year. Then next year, 2022, we would take our measure slate, collect the most recent publicly available data that are available on those measures, and pull that information together for inclusion in the next refresh of the ACO profiles. Our immediate focus then would be getting the right measure slate, getting the data together, and figuring out the best format for sharing that information with stakeholders via the profiles. The subsequent major refresh of our ACO profiles in 2024, after the next ACO certification cycle, could then incorporate some additional information on how performance has changed in the ensuing 2 years. That would open up the door to provide some recognition to those ACOs that have improved on the most metrics. Next slide, please. The exact metrics to display and the format for showing performance in the ACO profiles are both still to be determined, but we have arrayed here generally the sorts of information that would likely be published in each ACO's profile. There would likely be some characterization of cost based on CHIA total medical expense data. For display purposes, we would probably consider characterizing ACOs by thirds or quartiles of relative costliness, instead of listing actual payer-specific per member per month dollar amounts. The bulk of the information displayed would focus on clinical quality measures. Publicly available data thus far has tended to consist primarily of HEDIS measures and some patient experience metrics. So our initial measure slate will likely draw from those measures. But our intent is for this to be an evolving, iterative process as more data becomes available. We understand from our colleagues at CHIA that their own quality data collection will be evolving in the near future to incorporate more outcomes-based measures and align more closely with the Massachusetts-aligned measure set. As that data becomes available, we'd seek to incorporate such metrics into our display as well. Similarly, you can see here that we would likely include a look at health equity via stratification of 1 or 2 quality measures in the future. The EOHHS Quality Alignment Task Force is currently working on building capacity to do such stratification, and we seek to build on that work as it proceeds. Next slide, please. Lastly, I wanted to share a bit on our thinking as to how the final measure slate would be selected. First and foremost, our commitment to relying on data that is publicly available and curated by trusted partners like CHIA does restrict the universe of potential metrics that we can track and display. So we would look to metrics for which data are currently available publicly and for which we expect data to continue to be available in the future. At this time, in the commercial space, we understand that to largely be HEDIS measures, but as I mentioned, we know from discussions with our colleagues at CHIA that in the future, we can reasonably expect more outcomes-based metrics to be available as well. So there likely will be some evolution of our measure slate over time as that landscape evolves. And the more we can align with the Massachusetts aligned measure set over time, certainly we would seek to do so. We're also likely to consider salience to stakeholders. Which metrics are payers and providers focusing their energies on, and which metrics are likely to be the target of ongoing quality improvement efforts? CHIA does collect data on the number of active payer-provider contracts that various quality metrics are included in, so that may be a factor as well. Ideally, we would select measures in which there's some differentiation between the ACOs. Measures for which all ACOs are performing essentially the same or for which performance is topped out are not likely to be very interesting or meaningful. And finally, we may find that there are measures that reveal something interesting or noteworthy that we think ought to be covered in the ACO profiles. So these are all the things that could influence the final set of measures that we ultimately propose for inclusion in the profiles. Next slide, please. Now, commissioners, I'd love to get your thoughts on the questions that we've listed here. You can see that we're looking for general feedback on this approach and our underlying thinking. And any general advice on potential opportunities or pitfalls in this work would, of course, be much appreciated. And of course, I'm happy to take any questions you might have or otherwise open up the floor for some discussion. Thank you.
Are there any questions or comments for Mike? Thank you, Mike. It's a very well put together presentation, very clear. Stuart?
Yeah. All right. First of all, I like everything you said, but what seems to be missing, there's been a ton of research over the last, I don't know, 5 years about how successful ACOs have been on the national level. And there's been a ton of research about measuring outcomes and the differences of how you measure them. I would think that before we try to do anything independent in Massachusetts, we would thoroughly explore the national information. And we have here in Massachusetts the real leading experts, both at Harvard and at Brandeis, who've really focused on ACOs and where their performance are relative to non-ACOs. But this sounds like, we're sort of starting from scratch and we're developing our own measures. It sounds like the same debate we had when we created the ACO certification process in the first place. And we started talking about as if we were an independent entity. And then we decided to sort of try to build as much as we could on national data. Now, I don't know, I don't think it precludes much of what you've done, which sounds great. But before I would do any of this, I'd like you to show us how the national analyses about performance would fit into this.
Yeah, it's a point well taken, Commissioner. I will say that our intent here is certainly not to reinvent the wheel, and we really do want to align, particularly with what's going on in Massachusetts, but certainly nationally as well. And that's part of the rationale here for pivoting away from the original distinction proposal that we put out some time ago, and more towards something that draws from data collection efforts that are already going on and sort of existing performance transparency that exists out there. We'd be seeking here to kind of compile information that's out there, but is not necessarily compiled in one place and easily viewed for each of our certified ACOs. And so,
but you didn't even, Mike, I'm not trying to be critical, but you didn't, I think before you go into this complexity, I think we should see what has been done nationally. Now, a lot of the national analysis is whether ACOs save money relative for the Medicare program, which is one measure, and yours is much more complete and deals with a lot of other aspects like quality and equity and so on. So I'm not suggesting that you don't do what you're suggesting, because I like what you're talking about. But I'd like to see, before you do anything, of what we can learn from data that's already been collected. And more importantly, there's a lot of debate about what's the right measures. And there's been a difference between and Medicare itself has developed all kinds of evaluations, and they have one set of measures. And then there's someone like Dr. I think it's McWilliams at Harvard, or Rob Mechanic at Brandeis. And then they're a consulting firm. So there's been a lot of stuff done. And I, for one, would like to see that information before you do anything else. And you didn't, it isn't mentioned here, but I like the sound of what you're talking about, but I don't want us to sort of go off as if we're sort of starting from scratch.
Sure.
Okay, we have Dawn followed by Marty. So Dawn, please.
Thanks. Yes, a great beginning, Mike. Stuart, may not be able to say as strongly as I feel that Brandeis is a good go-to place, and Rob Mechanic would be a very important contact for what Stuart's talking about. I agree with him. I have two comments. One is I think we're on the right track, but there's a real risk here. Once a set of metrics is defined, the 5 to 10, for example, that you outlined, we enter a gaming realm of teaching to the test, in which the energies of the ACOs go to managing those metrics, which isn't the same as improving care comprehensively. And I don't have an easy answer to that, but I really would would urge you to keep a holistic view of the care they're giving, which isn't going to be captured by 5 to 10 quality metrics. What to do about it is a chronic problem in the industry, but let's not get into minimalist thinking. One idea would be to open the door for the ACOs themselves on their individual own initiative to report in stuff they're proud of, things that they're doing that are advances in their view, and we collect data. It'd be kind of another category, I guess, a sixth category in your data set, which would be self-reported good work that they want to make visible. That would be an example of welcoming something broader. The second comment I have is on the equity piece. You have equity parentheses future. I'm afraid I think we can't afford for future there. I think it's time to press it, and I would just say it has to be from the beginning. One of the ways we look at the data, or we're kind of missing the boat. So there's a couple of comments. I'm happy to help with any of that offline or at any time. Thanks.
Thank you, Don. Marty?
So I would agree with my colleagues. Mike, I think you did a good job. I think I think you've landed in a place that's much better than where we were going a couple of years ago. I think one point I want to stress is make sure we're aligned with the payer here, which is Mass Health, and where do they think the system needs to go, and make sure those are the things that we're incentivizing in terms of measurement. I would just also mention the Blue Cross Blue Shield Foundation of Massachusetts had a very interesting policy brief, I think last week or the week before, on value-based payments as they relate to children's health and wellness. And I think there were some recommendations there around data collection we may want to look to as well. But good start.
Great. Thanks, Marty. Any other comments?
Barbara, it's Chris.
Yeah, Chris, please go ahead.
A couple of things. First, to Stuart's point about national data, I think one thing that is really clear in the national ACO data is that physician-driven ACOs are far more successful than hospital-centric and hospital-driven ACOs. And I think you can't emphasize that enough. That data is clear now. Perhaps Don has a comment about it. With regard to new outcome measures, I guess I'll also echo Don in saying the risk of trying to be too granular here is going to be measured in a cost of time, and I think we should strive to try to keep it simple with regard to outcome measures. And there are two very, very clear and always collected data. One is hospitalizations, a subset being re-hospitalizations. That's two. And then the third is emergency room utilization. That's here and now outcome data. It's incredibly important. I like the notion of self-reported data. I have worked with groups that, for instance, if there are two chronic illnesses and no behavioral engagement, that's a negative outcome measure. So my point is, let's not try to study for 6 months what the national data is. There is some clear national data. I believe it's echoed by our own data. I can't remember exactly, but I know Atrius and Macaipa and other ACOs were performing at a much higher level than others in the past. So we know that. We don't have to study it. We know it, and it should be a driver. The last point is that we have more capability beyond Brandeis and Harvard, Stuart. You know, I'm going to just jump on you for that because my colleagues at MIT and Boston College and other places certainly feel like they could contribute here. So anyway, that's where I feel like we should move and move quickly.
Thank you, Chris. Appreciate those comments. David Seltz or Mike, or Kelly, any comments from you before we move on?
No, that was all very helpful. Thank you.
Great. Glad to hear that, Mike. Okay, then we will conclude this part of the conversation, and we are now moving on to discussion on our targeted cost challenge investments, which we have some very interesting feedback for you from the evaluation perspective. So let me give that to Kelly.
Thank you so much. And thank you, commissioners, for your helpful feedback on the last item. And thank you, Mike. Okay, so now we're going to make a somewhat hard pivot to another key aspect of the work we do in healthcare transformation and innovation, and that is our investment programs. And we're pleased to be here today to share highlights of findings from our Total Cost of Care Challenge investment program, which we are going to refer to henceforth as TCCI to save time. I'm joined today by Catherine McLean, who led the work in evaluating the program, to share key findings and lessons learned before we pivot to some questions for you. But since it's been a little while since this program launched, let me start with a brief orientation. So the TCCI program arose out of the HPC's recognition of a number of specific areas that represented perennial high cost and high utilization. After consultation with stakeholders, an investment program was conceived that would allow awardees to select from one of 8 cost challenges and deploy innovative evidence-based interventions focused on that particular challenge, with the aim of developing models that would improve care and reduce costs, thus positioning them for success in value-based payment environments. Ultimately, $6.6 million was awarded to 10 awardees over an 18-month period of performance beginning in 2016. Next slide, please. So while we don't have time today to offer an in-depth description of all 10 programs, I did want to give you the opportunity to see who the awardees are and their chosen cost challenge areas. So I mentioned earlier that we started with a list of areas of perennial concern. There were 8 options offered to awardees, but the awardees themselves ended up converging on 5 cost challenge areas: health-related social needs, serious illness and end-of-life care, site and scope of care, behavioral health integration, and care transitions and post-acute care. So due to the nature of these particular cost challenge areas, these programs ended up focusing on patients who had significant social vulnerabilities as well as clinical complexities. As a bit of a sneak preview, they also frequently relied on non-clinical workforces like navigators and community health workers who were able to forge quite close relationships with these patients, something that proved particularly important for people who started from a position of mistrust with the healthcare system based on past experiences of racism, feelings of stigma, or just generally bad experience. And they engaged closely with community-based organizations to meet, what turned out to be a really significant diversity of patient needs. So we will return to both of these themes later in our conversation. But now let me turn it over to Catherine to review some specific program highlights. Next slide, please.
All right, thank you, Kelly. Good morning, commissioners. I want to start with just a little bit of context for the approach we took to the TCCI evaluation. As Kelly illustrated a little bit, there there is a wide range of variation in these programs. You know, the nature of these very diverse cost challenge areas, and then our encouragement of innovative and diverse care models within them meant that there was considerable heterogeneity that was really intentionally baked into the program, but meant that we were working really more on an awardee specific level in our evaluation rather than looking at the cohort as a whole. All of the programs were informed by and based in evidence from other interventions and care models, but the implementation experience among the awardees varied, as some were testing, you know, and piloting promising new practices that their organizations hadn't previously tried, while others were building on programs that had gone through earlier implementation, testing, refinement. In general, the HPC and the awardees prioritized flexibility and adaptation to meet patients' needs during the program and to respond to on-the-ground realities. And this was prioritized over sort of quote unquote pure data and perfect adherence to some kind of protocol. The impacts of these choices are addressed in the evaluation report, as they do complicate a little bit some of the evaluation. However, you know, we were able for each of the awardees to look at what their implementation experience was, what they learned, and measurable positive impacts on patients. And so if we move to the next slide, while we don't have time again to get in depth with all 10 of the awardees, we did want to share just some highlights about the positive impacts that these programs had. Some of these are directly cost related, such as Brookline Community Mental Health Centers, reduction in total health expenditures, while others were more utilization focused. Hebrew Senior Life saw a decrease in ED transports by ambulance. Care Dimension saw a decrease in inpatient readmissions. And then still others were focused on you know, utilization and cost adjacent measures, such as behavioral health networks decline in homeless or unstably housed families in their program, and Berkshire Medical Center's considerable increase in access to outpatient behavioral health care. And then where we were able to look at all 10 awardees, we did find that the TCCI programs served over 3,800 patients in the Commonwealth and worked with more than 60 community-based organizations in partnership in order to implement their programs. At the conclusion of the funding period, 5 of the 10 awardees were able to continue their models in a manner much like it was implemented in TCCI's implementation. 2 did discontinue their programs, while 3 others were able to retain or continue portions of their model, often through somewhat creative means. For example, the Holyoke Public Schools wrote a grant to continue work similar to the work that Behavioral Health Network was doing, so that the Holyoke Public Schools could support homeless families in their school district. You can see data from all 10 programs in the impact brief that has already been released, and much more detail on each of these will be available in the evaluation report. And then if we can move to the next slide, another area we really focused in the evaluation of this program and the publications that we're putting out regarding it is the knowledge that was generated or affirmed from the experience of the TCCI program. The awardees' experience emphasized several important areas to consider when implementing care models to address healthcare cost and quality. Working across sectors with social service organizations proved critical in addressing patient needs, and also extended the capabilities of awardees by bringing in expertise in complex systems like housing. Many programs centered care coordination as a way to work across the healthcare system and ensure patients received care that was aligned with their needs and goals. Non-clinical positions, such as CHWs and other similar roles, had enormous impact working directly with patients to ensure engagement. And these relationships were an important part of the trust building which helped those who had been disconnected from care to engage with TCCI programs. And then in numerous programs, staff encountered larger systemic barriers like a lack of affordable housing or a shortage of substance use disorder treatment beds, which made meeting all of their patients' needs challenging. And that was a theme we sort of saw in several programs. So I'm now going to turn it back to Kelly, and we are happy to take any questions you may have. And then we also have a few of our own questions for you for discussion.
Thank you so much, Catherine. So let's pause and offer the commissioners the opportunity to inquire about this work.
Are there questions? All right, then, Kelly, why don't you proceed?
All right, next slide, please. You know, as Catherine mentioned, you know, there were some really interesting features that sort of popped as we looked across these different investment programs. And the questions that are here sort of relate to some of those areas. They actually follow kind of three very distinct paths. So I will leave it to all of you to decide where you want to lean in. I think the first one really relates to the notion of sustainability. As Catherine mentioned, to their credit, 5 of our awardees were able to maintain the programs pretty much as they designed them for TCCI. You know, 3 of them had to get creative. 2 of them found that it did not make sense to continue the programs. I would say, having read the report in great detail, a consistent theme across each one of them, even those that did sustain their programs, was challenges with alignment of the payment model. So I would be interested certainly in hearing feedback from this group that given the slower than expected adoption of APMs, how can we promote the sustainability of innovative care models that emphasize services that are not, you know, either reimbursable or don't make sense in a fee-for-service environment? So maybe we can start there, and if people have thoughts, then we can move on to the other questions. Commissioner Cohen, I see your hand is up.
Yeah, so I think it's a great question. But, you know, a lot of these models are funded through other sources, either through, you know, contracts with the various state agencies, local philanthropy. So I think, you know, there are, and, you know, another place is community benefit dollars, which hospitals have. So I think there's opportunities to take the, you know, what we've learned from here and think of applying them or getting the message out about what works to the larger set of stakeholders so that they can embrace these from with those other funding sources.
Yeah, I think that's a really good point. And I would say when we talk about, you know, sort of when Catherine mentioned creative solutions in air quotes, you know, really that is what I would say a lot of those awardees have done, is sort of tried to seek alternate sources of funding. But I think your point is well taken, that they will be better positioned to do that if we've got solid information about what works, what doesn't, the value to patients and the impact on patients. I see Commissioner Berwick's hand up as well.
Yeah, this is great stuff. You know, to your very first question here, Kelly, a small point would be make sure we're writing about the degree to which APMs support this kind of innovation compared to fee-for-service. I don't know if you've published anything on that, but this builds an even stronger case for getting out of the fee-for-service model.
It's a really good point. You know, it's funny that you mentioned that, because we oftentimes cite the lack of an aligned payment model as a problem. I think what you're advocating for is more of a glass half full approach to that, in terms of talking about what we could do if the payment model was aligned. And I think that makes a lot of sense.
Yeah, it's a chance to add to momentum in that direction, Kelly, just like you said.
Yeah. Chair Altman, I see your hand as well.
Yeah, well, this is partly philosophical, partly pragmatic. set of issues, and that is certain services that you've indicated sort of fall into the new area of social determinants or social services. And they have traditionally, many of them have not been defined as strict, narrow-based healthcare. And therefore, they're not listed either in the codes or whatever in the fee-for-service.
Mhm.
So one option clearly is where there is a service that's not currently in the fee-for-service arrangement, whether there is real good justification for moving it into the fee-for-service. So one of the areas is to get our healthcare package redesigned to include some of these services. Now, I say that with some trepidation because what's happening over time is we're medicalizing all kinds of social services because the medical community has more money than the non-medical community. And with medicalizing these, it brings with them some problems. And I think Marty and Don and others can articulate those pretty well. But nevertheless, I do think over time, we're going to begin to put into the traditional medical fee-for-service more of these services. Second, the previous discussion we had on ACOs and more global budgets or capitation would encompass those services which ultimately generate outcomes like lower spending. And therefore, one of the big justifications for alternative payment systems is the idea that by incorporating these extra services, over time, you're going to see reduced spending. So clearly, focusing on an alternative payment system like capitation or global budgets would do that. And then third, it's what Marty said. Some of these services, A, will not, should not, could not be in the fee-for-service. They're just by their nature different. And B, really are not designed to generate savings, but to improve quality. And by the nature of them, we are going to need other sources of funding, like Marty mentions it. So I think that there is a gradation of these three areas that you need to focus on.
We appreciate that advice. I think this is going to continue to be an evolving landscape where we have to be a little bit flexible and a little bit creative as our awardees are, but those points are all well taken. Now, I have a couple of additional questions here, but I'm also mindful of time. And I have a feeling there will be many opportunities to come back to topics related to workforce and community partnerships in the future. So I am going to, with Commissioner Blakeney's okay, suggest we move on to our next item, unless anybody has any last thoughts to share.
Final chance for any last thoughts. Thank you, Kelly. And as you say, I know we're going to be revisiting these as time goes on. Please keep us apprised if there are any time frames that you're bumping up against so we can facilitate.
Okay, thank you.
Okay, thank you. At this point, let us move on to the third and final agenda item for the day, which is the report on findings of certified nurse midwives here in Massachusetts. Kelly and Sasha are both up. So Kelly, let's go back to you.
Yes, I'm happy to pick it up here. We skipped past a final plug for some of the outputs related to TCCI. So let me just say, if you're interested in more than we had time for today, we have an impact brief, a care coordination report, and an evaluation report available for your reading pleasure soon. So, okay, so moving right along. Our next topic, as Commissioner Blakely noted, is an overview of the maternity care landscape in the Commonwealth, with a particularly deep dive into the role of certified nurse midwives. This is a topic that aligns with work that's happening across the agency, touching themes of care delivery transformation, cost containment, and maternal and child health. In recognition of the Red Sox win last night, as Commissioner Blakely noted, we have a double header with following a presentation at the MOAT meeting that preceded this one. Sasha Albert is back from our research and cost trends team to present her findings on outcomes related to the midwifery model of care in Massachusetts and offer some policy recommendations for facilitating nurse midwife practice, a topic that is particularly timely because this happens to be Nurse Midwifery Week. So from that fortuitous launching point, let me turn it over to Sasha.
Thank you so much, Kelly, and good afternoon, commissioners. I'm pleased to present highlights from our work on certified nurse midwives and maternity care in the Commonwealth. Next slide. So the Health Policy Commission has chosen to examine the role of certified nurse midwives and maternity care in Massachusetts for a variety of reasons. Labor and delivery is the top category of hospital admission among Massachusetts residents among age 65. And prior HPC work has found wide variation in both maternity spending and quality of care across hospitals. There are also ongoing equity concerns surrounding birth experiences and outcomes, which are the focus of two of our current investment programs. Additionally, we've long advocated for scope of practice reform and top of license practice for providers. At the same time, we're aware that scope of practice reform on its own may not be enough to truly transform practice. As a result, this work focuses on certified nurse midwives to understand outcomes associated with the midwifery model of maternity care in the Commonwealth, as well as barriers to full and independent practice apart from legal scope of practice. Next slide. Give a quick sense of the landscape of maternity providers in Massachusetts. Many types of providers care for the nearly 70,000 births each year in the Commonwealth, including physicians, nurse midwives, certified professional midwives who mainly attend home births, nurse practitioners and registered nurses with OBGYN specialty, and doulas. Next slide. Certified nurse midwives are one of the 5 types of advanced practice registered nurses in Massachusetts and have had expanded legal scope of practice since 2012, meaning that they do not legally require physician supervision in order to practice, prescribe, or bill. There are 2 philosophies that can shape birth care. One approaches birth as inherently risky and in need of detailed surveillance to minimize adverse outcomes, which can sometimes lead to premature or unneeded interventions. In this approach, there's a chance that providers' sense of risk can override patients' preferences for their care. The other philosophy treats birth as a normal life process and practices a model of watchful waiting, seeking to avoid interventions in the absence of serious complications and centering the birthing person in decision-making about their care. And it is the second model that's emphasized in midwifery. Using this approach, nurse midwives provide a low-intervention, patient-centered model of maternity care for birthing people with low and moderate risk pregnancies and deliveries, and they care for patients both separately from and collaboratively with physicians. Midwives are primary providers for maternity care in most high-income countries, but their role and presence varies widely across hospitals in Massachusetts. Next slide. Existing research finds that increased use of midwifery care is associated with improved patient outcomes and lower spending, including lower rates of maternal and infant mortality, lower rates of preterm birth and low birth weight, fewer interventions, including lower cesarean and episiotomy rates, shorter length of inpatient stay. Our study aims to add to this existing evidence base about midwifery care. Next slide. The midwifery model may also help to address continuing racial disparities in birth outcomes. To give just one example, both nationally and in Massachusetts, birthing people of color, especially Black birthing people, are more likely to experience severe maternal morbidity than white birthing people. Research finds that birthing people of color report adverse experiences with pregnancy and birth care when they do not feel heard, or when providers are dismissive of their concerns. And the model of patient-centered care provided by midwives may help to improve pregnancy and birth care for birthing people of color. Next slide. Despite favorable outcomes associated with midwifery, the US has the lowest proportion of midwives as maternity providers compared to other high-resource countries. We have 15 providers of any kind per 1,000 births, only 4 of whom are midwives. While Massachusetts has a higher rate of midwife-attended births than the US as a whole, 17% here compared to 10% nationwide, it's still far below rates of midwifery care in other high-resource countries, where midwives attend over half of births. Next slide. Moving to data and methods, we use a variety of data sources for this work, including 2017 commercial claims, 2017 birth records from the Department of Public Health, the Department of Public Health's biannual nursing licensure survey from 2018, and Leapfrog hospital quality metrics as reported to CHIA. Next slide. We also met with a variety of hospital, midwifery, and physician stakeholders as part of this work. Now moving to a little background on the landscape of maternity care in Massachusetts. In Massachusetts, 99% of births take place in hospitals. This is a slightly higher rate than in the US as a whole. Out-of-hospital births include home births and births in birth centers. We see home births on the left-hand side of the graph and birth center births on the right. And in both cases, Massachusetts has lower rates than the US as a whole. Moving to insurance coverage. In 2017, about 2/3 of Massachusetts births were covered by commercial insurance, as shown in the medium blue on the right. And, shown by the medium blue on the left. And about 1/3 were covered by Medicaid, as shown in the darker blue on the right. Now moving to findings related to variation in midwifery care across the Commonwealth. This map depicts hospitals both with and without midwifery care as of 2017. The orange circles are hospitals that reported midwife-attended births, while the blue circles are hospitals with no births attended by midwives. We also have one birth center in Massachusetts that is not affiliated with a hospital and that opened after 2017, which is shown as a green circle. This map also includes 5 X's to indicate the 5 hospitals whose obstetric units have closed since 2017. The orange X's show hospitals that previously provided midwifery care, being Holyoke Medical Center and Toby Hospital. And the blue X's shows hospitals whose obstetric units have closed that did not provide midwifery care, Harrington Memorial, Falmouth, and Morton hospitals. I want to point out that since our study uses data from before when these hospitals closed their obstetric units, we do include data from these 5 hospitals in our analysis. Next slide. So taken to a regional level, we see that the rate of hospital births attended by midwives varies widely by region. Where on the previous slide, we saw blue circles southwest of Boston indicating hospitals without midwifery care, this map shows no births attended by midwives in the Metro West and Norwood areas. Likewise, the high concentration of orange circles indicating hospitals with midwifery programs in the Pioneer Valley translates to over 30% of births attended by midwives in that part of the state. As we saw in the maps, most Massachusetts hospitals with maternity beds do report at least some midwife-attended births, even though rates of midwifery care at each hospital vary widely. The bars in this graph indicate the number of births per hospital, with the blue portion representing births attended by physicians, and the orange indicating births attended by midwives. On the next slide, we'll be zooming in on just midwife-attended births. And here we see that the proportion of births attended by midwives in each hospital varies substantially. The bars in this graph indicate the proportion of births attended by midwives at each hospital, ranging all the way from 0 to nearly 70%. We can also see that there is wide variation by hospital cohort, as shown by the dots under each bar. The blue dots indicate community and community high public payer hospitals. The orange indicates teaching hospitals, and the yellow is for academic medical centers. 9 of the 10 hospitals on the right-hand side of the graph, with the greatest proportion of midwife-attended births, are community hospitals. Although we do see BMC as an academic medical center with a relatively high proportion of midwife-attended births at 26%. Next slide. Broken out by hospital cohort, nearly half of Massachusetts births in 2017 took place at academic medical centers, as shown in the blue bars. And academic medical centers as a group also have the lowest rates of midwife-attended births, as shown in orange. Our prior work has found that the share of deliveries taking place in AMCs has increased over time as the share of deliveries in community hospitals has fallen. Next slide. Why do we see all this variation from hospital to hospital in terms of how rates of midwifery care vary from one hospital to another and in whether hospitals offer midwifery at all? According to the stakeholders we spoke with as part of this work, there are a variety of factors. These include hospitals' unique history, whether a long history of midwifery care or a history of difficulty retaining OBs. Another factor is physician and leadership understanding of the midwifery model of care and either willingness or interest in collaborating with midwives. Additionally, how hospitals define obstetric risk and which patients are appropriate for midwifery care plays a role. Another factor is having a care model that offers patients an opportunity to learn about midwifery and to choose which type of maternity care provider they would prefer, since different hospitals place different amounts of emphasis on patient education about their provider options. And lastly, we heard that patient awareness of or interest in midwifery can motivate maintaining or growing hospital midwifery programs. Digging a little deeper, we spoke with 4 hospitals where certified nurse midwives have a significant role. Each hospital had between 30 and 70% midwife-attended births as of 2017, but their midwifery programs all worked a little differently. Just to give a few examples, one hospital does not have midwives provide prenatal care. Rather, obstetricians provide prenatal care, and midwives are on call as inpatient laborists, which is analogous to hospitalists, for the majority of deliveries. At another hospital, nurse midwives provide care from prenatal through postpartum and for all deliveries except scheduled cesareans. Yet another hospital offered the option of birth center delivery for interested low-risk patients prior to the COVID-19 pandemic. Notably, all hospitals have a different approach to determining which pregnancies or labors are too high risk for midwifery care, including whether they treat high-risk pregnancies as necessarily leading to high-risk labors. For instance, some hospitals consider all patients with gestational diabetes as too high risk for midwifery care, while others would say that only patients whose gestational diabetes requires medication management cannot be cared for by midwives. And it's this type of nuance in how these decisions are made that contributes to varying rates of midwifery care. We'll now turn to outcomes associated with midwifery care in Massachusetts. The next set of slides will start by showing patterns at a high level, and then we'll share results of an analysis where we adjust for a variety of factors. Additionally, I'd like to note that we use hospital-level birth record data from DPH on our rates of midwifery care and our outcome analyses because it's difficult to capture nurse midwife involvement in births from commercial claims. To start with, we found that hospitals with higher rates of midwifery care have lower rates of cesarean births and lower rates of episiotomies. On cesarean births, on the top of the slide, hospitals with the highest rates of midwifery care had the lowest rates of C-sections at 24%, compared to 25 and 26% at hospitals with lower rates of midwifery care. More striking is the relationship between midwifery and episiotomy rates. Hospitals without midwifery care had an episiotomy rate of 7%, compared to just under 3% at hospitals with the highest rates of midwife-attended births. Next slide. The relationship between midwifery care and episiotomy rates is especially striking when broken out by individual hospital. As rates of midwife-attended births increase, as shown in the blue bars, episiotomy rates decrease, as shown in the orange scatter plot. On spending, hospitals with higher rates of midwifery care see lower spending on average for the full episode of maternity care from prenatal through postpartum, with about $21,000 at hospitals with the highest rates of midwifery care, compared to $22,000 to $28,000 at hospitals with lower rates of midwifery care. Next slide. When we adjust for a variety of patient and hospital level factors, our analysis finds that a 10% increase in the rate of midwife-attended births in the Commonwealth would come with a $530 reduction in maternity spending, 3,560 fewer cesarean births, and 860 fewer episiotomies. Shifting our focus now to barriers to midwifery practice, researchers at the University of British Columbia who have studied the integration of midwives into the health system of each US state found that Massachusetts ranked 32nd on the integration of all types of midwives and 14th on the integration of nurse midwives into our health system. We rank 14th on the integration of nurse midwives into our health system, in part because most hospitals in Massachusetts do not allow certified nurse midwives to admit their own patients. Instead, must admit patients under a physician's name. Next slide. While nurse midwives have had expanded scope of practice in Massachusetts for nearly a decade, that has not necessarily alleviated barriers in other areas. Hospital bylaws often exclude all types of advanced practice nurses from their medical staff, and as mentioned on the previous slide, require nurses to admit their patients under a physician's name. Commercial payer policy can also constrain practice with additional payer-specific credentialing requirements, or by requiring nurse midwives to list a supervising physician in order to bill, regardless of whether or not they actually have a supervising physician. Likewise, commercial payer policy can incentivize incident-to billing, in which care provided by a nurse is billed under a physician's name if a physician is in-house or is involved in any way in patient care, even if a nurse midwife was the primary provider. This may incentivize having a physician get involved in care or take over aspects of care just for billing purposes. Lastly, and less concretely, cultural barriers remain. Nurse midwives do not always have input into decision-making around which patients are appropriate for their care, and research has found that physicians may not always be willing to share influence over the practice environment. We also heard in our meetings with stakeholders that how these decisions are made and who is able to give input varies widely by practice. Next slide. There are also persistent barriers to expanding and diversifying the Massachusetts midwifery workforce, one of which is that we have only one midwifery education program in the Commonwealth. Additionally, most nurse midwives in Massachusetts are white and non-Hispanic, and research has found that prospective midwives of color can face experiences of racism in midwifery education or when participating in midwife professional organizations that can impede their entry into the profession. At the start of this presentation, we noted that Massachusetts has very few out-of-hospital births, and I'd like to return to that topic for a moment to note that there are few options in the Commonwealth for individuals who seek a less medicalized setting for birth. Birth centers can offer low-intervention, nurse-midwife-led care and may be able to provide more options for local births in areas where relatively low birth volume creates access challenges. Obstetric care is typically a low-margin service for hospitals, and as we've noted, low birth volume areas of the Commonwealth have seen 5 hospital obstetric units close in recent years. However, opening and operating birth centers that are not affiliated with hospitals is difficult due to policy and regulatory barriers, including the requirement to have a single physician as medical director and lower reimbursement rates for midwifery. Next slide. So in summary, increased rates of midwifery care in Massachusetts could lead to lower costs and improved outcomes and could help to address longstanding disparities. Despite Massachusetts granting expanded scope of practice to nurse midwives as of 2012, hospital and payer policies often continue to restrict autonomous practice, and barriers continue to persist in both expanding and diversifying the Massachusetts midwifery workforce. We have a few proposed recommendations, and we welcome feedback from the commissioners. We recommend increasing and improving the use of nurse midwives by improving patient education, as well as public understanding and awareness of midwifery, including increased opportunities for patients to choose their provider type for birth care. We also recommend using payment models that are neutral to provider mix. We recommend facilitating nurse midwife practice by encouraging hospitals and payers to align their policies with state law that does not require nurse midwives to practice or bill under physician supervision or to admit patients under a physician's name. And we recommend supporting alternative birth settings by alleviating barriers to the establishment and operation of birth centers. And here I'd like to note that Mass Health has issued a bulletin on how to pay for birth center births fairly recently. Thank you so much. We appreciate the opportunity to share our findings today, and we look forward to releasing our full findings later this fall.
Thank you so much, Sasha, for an outstanding report and a very clear delineation of the benefits and the barriers to nurse midwifery practice. Are there any questions or comments for Sasha?
I hate to dominate, but that was great, Sasha. And what jumped off the page was how different the United States is from other countries, particularly Germany. I wonder whether you could do a little digging to find out why, and whether in Germany it's cultural or it's economic or what. I mean, the numbers are so stark. Just, but it just may be cultural and, we're going to be different than Germany and there's no way of us becoming Germany, or it's really incentives that are set into their system.
Absolutely. Yeah, I think that would be worth investigating. We haven't learned as much about Germany in our work so far, but I can say that we've learned a little bit about how things work in the UK under the NHS. And from what we've learned, it sounds like midwives are involved in all births to some capacity, even births that are too high risk or too clinically intense for midwifery care, which does mean that they have a little bit more input into decision making. There are more midwives. They're better integrated into the health system here than midwives are here. And I wouldn't be surprised if there's sort of a similar difference in the way that practice is structured in other countries with higher rates of midwifery care, but we can certainly investigate.
You know what I would suggest you do, and that is talk to the Commonwealth Fund. They are by far the most knowledgeable, or have access to the most knowledgeable people about how other countries work. Rather than, the alternative is to send you to Germany, but
yeah, talking to the Commonwealth Fund would be a more efficient way of getting at that for sure. And that was actually their research that we were citing on that slide.
Okay.
Any other comments or questions? Kelly, I'm sorry, was someone?
Yeah,
Don,
that's Chris.
please.
Or Don.
Oh, hi,
Go ahead,
hi,
Don.
Don, please go ahead, and then Chris will follow up with you.
Sasha, thank you so much. Just to dot one I on the idea that hospitals with higher rates of midwifery care have lower C-sections and fewer episiotomies. One would really want to go into detail about apples to apples comparisons in terms of patient risk, incoming patient risk. And I don't know that research, but it's a little bit vulnerable to assume that those patients are comparable at the start, unless you're looking at, say, initially the very low risk patients, or if there were randomized assignments, which is very unlikely.
Absolutely, yeah, that's an important consideration in exploring the relationships between midwifery and intervention rates. According to the literature and to sort of other sort of clinical sources, fewer than 10% of deliveries are really truly the highest risk and truly have no other option than the highest clinical intensity of care. It's a little bit of a difficult knot to untie because the model of midwifery care is designed to avoid interventions. But on the other hand, there are some patients who will definitively need interventions and could never be seen by midwives. And we are not presuming to be able to sort of draw any clinical conclusions in our work. That's really not our area of expertise. But I think it's clear that there are a greater number or a greater share of patients who could benefit from midwifery care than are currently receiving it.
I also just add something for Dawn, and I know Sasha went by this slide fairly quickly, but she did control for a number of hospital and patient level factors in that analysis that are related to risk. And I'm partly, putting a lot of weight in these results because, as we found and talked about, the variation in midwife attended births from 0 to 70%. I mean, most of that is really not because of anything about a different patient population, but it's really just somewhat idiosyncratic. It's related to the culture of the hospital, the history of the hospital, and other factors. And that, I know it's not a randomized controlled trial, but that generates a lot of the kind of randomness you'd want in a study such as this. But your point is also fair, that you're never perfectly controlling for all of those factors.
Okay, thank you, David. Chris, you're up, and Marty, you're up after him. Chris, you're on mute.
Can you hear me now?
Yes, we can.
Okay, thanks. This looks like compelling data. Sasha, I disagree. I think it is there are clinical conclusions here. Cesareans and episiotomies are clinical conclusions, and significant ones at that. And I, mindful that anytime you're talking about licensure and scope of practice, the data has to be as grounded as it can be. And I guess I'm reiterating that while it looks like outcomes across a wide range of variables are significantly better, there needs to be someone, I don't know whether it's us or somewhere else, where we can gather data on perinatal morbidity rates for high risk cases. That's the clinical outcome that is probably the most significant. So we got to get that.
Thank you, Chris. Marty.
Yeah, so Sasha, for your double header, two big wins. Great job. I just have one comment, which is, Stuart said what popped out for him in this presentation was the difference to Germany. What struck me was just the difference across hospitals in Massachusetts. I mean, we have so many hospitals not using midwifery, and then so many hospitals successfully doing so. So it's interesting. As was said, I think a lot of that is just how they're used to doing business.
And Sasha, do you happen to recall off the top of your head the number of hospitals that required nurse midwives to admit through a physician's privileges? Do you happen to recall that?
Unfortunately, I don't think we were able to do a true census of hospital bylaws, but to my knowledge, it's almost all of them.
Almost all of them. Okay.
Yeah, I think some of the hospitals we spoke with in stakeholder meetings said that they were, investigating changing that. But at the moment, it should be almost all hospitals that have this practice.
Okay. An interesting question to come back with them on the broader issue of advanced practice nursing is, what do they do, or do they allow nurse practitioners who are practicing in, for example, a family practice or a primary care practice, do they allow those advanced practice nurses to admit either? It's just an interesting additional question. You're in the ballpark. So maybe, see if you can ask that question as well.
Yeah, thank you. I believe, again, off the top of my head, and we can investigate more. Yeah. I believe all types of advanced practice nurses, if they're not included in the hospital medical staff per hospital bylaws, would not be allowed to admit their own patients.
Right. Okay.
So I think it's less of a distinction among types of nurses and more sort of individual hospital rules.
Okay. Curious to know that answer, though, but thank you very much. That's clear. Any other comments or questions? This is, this is a critical piece of work. Kelly, let me ask you and Sasha and others, what are the next steps here?
Yes, so I can start there.
Okay, thank
you. As we said at the beginning, this is just highlights of our findings in this area. We had, a few more pieces of detail that we wouldn't have had time to include today. So our goal is to incorporate feedback from the commissioners and to publish our full findings in the form of a chart pack later this fall.
Okay, Kelly, any other feedback?
I think we've covered everything. Thank you.
Okay. Let me just thank the staff for a great presentation on some very important work. It seems clear between the meeting prior to this, the MOAT meeting, and now our meeting, this has been a heavy duty product producing meeting that has just been fantastic to participate in. So I, on behalf of the commission members on this committee, thank you all very much for an incredible amount of work under very, very difficult, continually difficult circumstances. Chris, Chris, are you suggesting you might want to say something?
I'm just doodling.
Oh. Okay. David Seltz, is there anything to wrap us up?
Thank you, Commissioner. Thank you all commissioners, especially those who stuck it out for the full 3 hours. Just an incredible morning and into early afternoon. Special thanks to Sasha for the double header, great research presentations. But thank you all. Commissioners, we will have an upcoming meeting in November with an executive session that we informed you about. But really the next big event is our cost trends hearings on November 17th. So please register members of the public if you haven't already. And commissioners, we will continue